Good evening, everyone. We welcome you all to Ortho TV online One Speakers, One Talk series. I hand over the proceedings to Dr. Shivashankar to introduce the speaker and the moderators for today.
Thank you very much, Neeraj. I take this opportunity on the Doctor's Day to welcome all of you for this One Talk, One Person webinar on management of hand injuries by Dr. S.C. Halder from Halifax, England. Since we have already heard about Dr. Halder in our earlier talk, let me change the presentation pattern. Let me introduce the panelists first. We have a very good panel of expert hand surgeons in the form of Dr. Abhijeet Wahegaonkar from Pune, Dr. Pankaj Ahire from Mumbai, and Dr. Parag from Thane, apart from Dr. Neeraj, Bijlani, and Dr. Ashok, Shyam of Ortho TV, who will be moderating the questions taken from the YouTube and Ortho TV channel. To introduce Dr. Abhijeet Wahegaonkar, he has done MBBS, DNB, MS, MCH, Ortho, and also he has worked in Mayo Clinic and has got his MS CTSA degree from there. He is adjunct professor of hand surgery, distinguished clinical tutor of orthopedic surgery, director upper limb, hand and microvascular surgery fellowship program, consultant and head of the department of upper limb extremity and hand and microvascular reconstructive surgery at Sancheti Institute of Orthopedics and Rehabilitation, as well as he works in Jahangir Hospital, Pune. He has 36 peer-reviewed publications, 12 textbook chapters on hand. He has read more than 300 papers and 60 invited talks in international and national conferences. He is visiting professor to Shahid Bahechi University, Tehran, University of Strasbourg, France, and also in Taiwan. He is the founding president of Wrist Society of India. He is member of many boards like American Society for Surgery of the Hand, French Society for Hand Surgery, then the European Wrist Arthroscopy Society, International Wrist Investigation Workshop, founding executive council member of the Asia Pacific Wrist Association and chairman of the IT committee. He is also on the executive committee member of Maharashtra, that is the Maharashtra Orthopedic Association, and is chairman fellowship committee of Maharashtra Orthopedic Association. This is Dr. Abhijeet Wahegaonkar. Right now he is busy with emergency surgery. He will be joining shortly in another 5-10 minutes. We have Dr. Pankaj Ahire from Mumbai. He works at Godrej Memorial Hospital, Nanavati Hospital, and Holy Spirit Hospital, as well as Saifia Hospital as a consultant hand surgeon. He is honorary secretary of Indian Society for Surgery of the Hand. He is member of Bombay Orthopedic Society, American Society for Surgery of the Hand, then International Wrist Investigation Workshop Society. He is also a member. He has special interest in wrist trauma, wrist arthroscopy, sports injuries of the upper limb. Welcome, Dr. Ahire. The third person we have is Dr. Parag from Thane. Parag is an orthopedic surgeon, hand surgeon from Thane. He is trained in hand and reconstructive surgery from Bombay Hospital, Ganga Hospital in Coimbatore, as well as from Singapore. He is in practice for the last 8 years in Mumbai. He has special interest in brachial plexus and peripheral nerve injury, wrist and hand fractures and crush injuries of the hand. He was the past executive committee member of Indian Hand Society and has experience of operating over 3,000 simple and complex hand injuries. He is national faculty for many of our meetings and conferences. Welcome, Dr. Parag for this today's webinar by Dr. Subhash Halder. Friends, Dr. Subhash Halder, we have already heard. He is basically from Calcutta, did his graduation and post-graduation from National Medical College, Calcutta. Then he moved to England, worked as a SHO and registrar at various hospitals. Then between 1978 to 2002, he has worked as associate specialist in orthopedics at Carderdale Royal Hospital in Halifax, which is near Manchester. In 2002, till present, he is working as consultant orthopedic and trauma specialist at Carderdale Royal Hospital in Halifax. To mark 1 million gamma nail, friends, I'll just remind you again, he is the person who invented gamma nail and it was patented by him. So to mark 1 million gamma nail, so the Stryker Medica people gave him a golden gamma nail in that ceremony. He is very much associated with Indian soil. He has been coming regularly for our Indian orthopedic meeting. This is in 2006 when I met him for the first time when he was the faculty on our nail subspecialty meet. Then in 2012, he had come to Udaipur for the Nails Con. This is him at Udaipur. Then 2013, I invited him to Maharashtra for the Meet the Master activity of Maharashtra Orthopedic Association. Without any hesitation, he accepted our invitation and came. Even he came to Sholapur 2 years back when he conducted a workshop here on Halifax nail. Then he has attended our operative nailing course also as a faculty. These are his pictures in 2017 during the operative nailing course. Then in 2017 itself, he came again for NailsCon Corbett, and recently, just in the month of November, December, he had come to Wahegaonkar, Kolkata also. So he has been, I am associated with him for the last almost 15, 16 years, and he has been very kind to come on any of the meeting which I have invited him, including today's webinar. He is a general orthopedic surgeon interested in trauma, but he does a lot of hand injuries. That is the reason why I thought it's good to hear this talk from a general orthopedic surgeon with a vast experience, almost 50 years of experience in treating these injuries. So this is the last time we had his talk on gamma nail and Halifax nail. Those who have missed to see this talk, they can visit this website bit.ly/orthotv.-SC Halder, and they can listen to his beautiful talk about intertrochanteric fractures, how to reduce and insert the gamma nail. Friends, I'm not going to stop here. He has invented so many things. One of them is a tri-flange wire for a nail to interlock. So this is a humerus interlocking nail which he has designed. This is Dr. Halder's nail. This is how he uses. So I will be requesting him to come and join and share his experience sometime in the near future on this. This is a comminuted fracture shaft humerus treated with this innovative nail, and you can see the retrograde nail with that. Without opening the capsule or the shoulder capsule, the fracture has united. Another badly comminuted fracture, head of the humerus with, you can see there is dislocation and the head is split. Again, he has treated by his, he's an innovative man, and he has a gifted hand. He does this reduction percutaneously, and he has inserted this implant and the screws, and you can hardly see the incision on this person's shoulder. Another nail is similar nail for the femur, a comminuted fracture shaft of the femur. As we all know, distal locking requires a lot of radiation due to freehand technique with which we do. So here with this nail, the radiation which the surgeon gets during distal locking can be totally avoided by using this tri-flange wire, which gives equally good rotational stability because of the special metal these tri-flange wires are made of. Can anybody think of doing a nail for such a distal fracture? It's only probably Dr. Halder who can think of doing nailing even in such a distal fractures to get union in them. Even for tibia, he has got the tibial nail. You can see some of the pictures. Fracture united with the comminuted distal tibial fracture, almost going to the plafond. Another very distal tibial fracture with a comminution. You can see that also has been beautifully reduced and treated by his nail. You can see the blue mark, which is the fracture line, which is extending so low. And this is the clinical function as well as the union with the restoration of the anatomy of the distal tibia. Friends, this is Dr. Subhash Halder, an innovative man, and I present to you and I request him to start sharing the screen and start the presentation. Welcome, Dr. Subhash Halder.
Thank you, Shiva. Thank you very, very much. I don't think I deserve that much what you have said to me now. I'm a simple, ordinary guy doing the work every day. But I'm just very much glad to hear all the panelists what is here now is very, very good. I'm so glad, think, and proud to have that kind of panelist which is nearly internationally famous people. Dr. Pankaj, Ahire, and the Abhijeet Wahegaonkar, excuse me, and the Parag lad, and the Neeraj Bijlani, and Ashok Shyam. Thank you very much for my show today. As I said, please, I am simple, ordinary guy. I will not show any complex things. This talk, as I said before, it is for the ordinary learning doctors. And I want to show a few simple, ordinary fracture, how we can treat without further going any complications.
Yeah.
So should
you can share the screen, sir.
Okay, I'll share it now. It's going on. So I will say the management of the hand fracture. Just a few of the factors. First, the phalangeal fracture. Then
No, you have not shared the screen yet.
Oh, beg your pardon. Let's go back on there.
Yeah.
Is that now?
Yeah, now we can see the, yes, your desktop.
Okay. Can you see now?
Yes.
So first is the management of the hand fracture. So I will show all the bony fracture. And first I'll few of the phalangeal fracture, then I'll go for metacarpal fracture, the neck and shaft, then the metacarpal fracture non-union, and few of the scaphoid fracture as well as the non-union. So I'll start with this phalangeal fracture. You can see this small little fracture. It suppose seen by the consultant, ask the register to put a little wire down there, registers for the SHO. You do it because that's the way we do the training from this SHO register and the consultant. And when he finished that wiring, he is saying that it is not really holding that much. Now, showing that X-ray, I'm really not daring to criticize the doctors who is doing them there. I never dare to do that thing. But what I am trying to explain here, that's doctor, how much problem is fixing this little fracture. You can see that. First, that this, all the fingers of the patients is interfering his X-ray. So somebody had to look after this finger. Then he had to hold this kind of, this little finger. Look at your little finger, see how much amount of space you got to pull it to give the reduction, as well as same time you got to put the wire, and the same time you have to save your hand from the radiation. It is quite difficult, challenging job to keeping all the things to fix it up. Whether you fix it right or you save your hand from the intensive radiation. So it is not, I'm here to blaming, I'm here, this simple ordinary guy, how is facing the problem in the theater, we don't look at that. At the end of the day, we try to criticize that couldn't manage to finish the simple little fracture of the K-wire. But we have never thought that how much problem he is having. So I came up with some kind of idea how I avoid that kind of problem in theater. Suppose this is a finger there's a problem here. If we're going to do the things, this all the fingers is going to interfere during my operation. So first thing, I put the thumb down inside and flex it up and bend it like that way, take all the fingers away from the operative field. So this is the area is a broken area. So I can easily pull it and do this job. How I do the things, I hold the injured finger up, put the flex thumb and wrap up this 4 inches crepe bandage few times in the over the wrist and flex it up over the thumb and flex the thumb as tight as you can possible to do the thing, because it's the elastic bandage. Sometimes you get loose. And then wrap it up around the things, come back with the other fingers. Leave it all of the fingers away from the operative field. So this the finger is free now. So you can do whatever you like it. The next problem is how can you maintain the traction? So this is the injured finger, I bandaged it up. Now you got to put the on 1.2 millimeter K wire, go just juxtapositions of the skin and the nail, because this is that germinal layer. So you got to avoid that bit. Sometimes this is a DIP zone. Sometimes I go either here or sometimes I go the neck of the second, the middle phalanx. So it depends on the type of the fracture. So I put the K wire down inside, go through and through, and put the one wire holder and bend the K wire over the wire holder. You must put the K wire. You cannot bend it, or you should not bend it just without put the K wire. I'll tell you why. And then on both side exactly same way, like that way it will die. If I'm going to bend it without holding the K wire, it will bend on the bone inside, and when you're going to take it out, it will be quite difficult, damaging the bone. So I had to take these precautions beforehand. So that's the way I can secure these fingers that way, and now I can have a sustained tractions with the assistant do that thing away from the radiations. So this is the area is kind of damaged. I can do whatever I like it without kind of problem with the other patient's finger, as well as exposing to radiation. So either my hand or the assistant hand. So that's the first steps I do the things. So that's that way I started doing things for a long time. Now this is the patient, he's our radiographer. He's got diaphragm kind of injury. And one of my colleagues saw and she sent her home, and next day come back to my next day. This X-ray showed by that colleague, the Subhash, can you have a look? Says, yes, where is the patient? So I send him home. So what happened, these kind of things happen always, that send the patient home just for the second opinion and just cover it up. This showed me. I'm say, I think we would like to see the patient. So then I can realize it is our radiographer. So I brought her back here. So I don't know how there's experienced surgeons like you all are do these kind of things, but what I do, I'll tell you. I do exactly the same, bandage it off, and they put the traction down that way. That is that kind of injury area. I put a small incision down there with that area. I got before that I got to tell you, I got this small instrument cut 2 millimeter. It is osteotome, very thin, very sharp, and made an incisions exactly along the fracture at this area, and then go down there, putting down the osteotome and just rotate it up and just elevate the die punch. After elevation up that way, and because it is a big opening up, I put the towel clip, just hold it together, all the soft tissue, not crushing down that way. So lifting the, crushing the, what you call this, this die punch, as well as this fracture, which is become displaced from this volar side. And then one put the 1 K wire from the dorsal to volar side. I put it down that way and cut it down the sharp end and put it back again up to this, up to that tendon area, flexor tendon area, making that your working length better positions. And that's the way I put this 4 other K wire. And that is the reduction I got it at the end of the day, and put this kind of cement. In theater, all the cement which is date expired, they save it for me because I use this kind of things on that. That is kind of expiry date cement, I use it. So this is that kind of fracture. That is that at the end of the day when I discharged her from the clinic, and she's still working in our theater, in our radiography department. So that's the way I can elevate these diapunts rather than leaving them. This is simple also fracture is going to polar displacement as well as a die punch. Exactly similar way I was doing, putting it up, bandage to the fingers and traction down that way. And this one I make a small incision down that way. And then put this 2 millimeter osteotome down there and rotate it up and then elevate it up. And you can see I managed to elevate quite reasonable, all right, with maintaining the articular surface. And then I again towel clip, just holding the crushing down that way so that it doesn't displace any further. So I put that 1.6 millimeter K wire by the side of the articular surface. And again, I cut it down the sharp end, pull it back to have a better working length and fix it up other two more K wires on either side and fixed with the cement. And at the end of the day, we'll get the result when about 3-4 months time. You can stop me if you want to question my that way. There's another fracture. You can see that it is a bit, not only this diapons as well as it's called T-type fracture is broken in between also in the volar side. And exactly same way, I put this time on the neck area. And then I put a little bit of depression down there. I rotate it up, or I put the osteotome, rotate that way and elevate that way. Now you can see that I managed to elevate quite reasonable. These places, if anybody not used to that way, you've got to be careful because otherwise mishandling of this osteotome, it might displace whole kind of articular surface. So I put the K wire back. This time I put the K wire back from the volar to distal because I thought that it will be better off take one piece on it with this my K wire because if I come that way, I might displace back that way. So this time I go to the volar to dorsal and pull it back, and then its other side is already cut. So do not do any more further. And then I put few more K wire, 2 more K wire either side. And you can see that articular surface reasonably maintained and put the cement that way. So that's that end of the result. And there's a movement of the finger, sorry, over. Here you will get it. Now again, this is the X-ray. It's not very, what we call this difficult fracture, but simple subluxations with the volar injury. But look at that. This is the 3rd time reduction by one of my colleagues. So what's happening here? This bend is creating more problems rather than doing any good. But that's one of our colleagues is doing that way. So after that, nearly 2 weeks time, it's come back to my clinic. So same, I took my theater. I just simple put a one, it's called anti-gliding K wire, and just 2 more K down there, put in the cement. And it was 10-minute job. But this poor man was suffering for 2 weeks. When I came back to here, it is near about 3 weeks. And that's the result. You will get it after 4 weeks' time. And again, this is a kind of fracture, is more dorsal as well as volar fracture as well as the displacement at the joint. Now, procedure stereotype, exactly same. I put it this time in the neck of the traction and fingers away from there. Gentle traction continue. And here what's happening after traction, you can see this volar, so the dorsal one is completely displaced from there going to the proximal displacement. So I try to put on a K wire, try to lift it up. When I try to lift it up, it is going further kind of displaced from the laterally or rather dorsally. So to avoid that bit, I try to put the towel clip to crush it down that way. I reasonably did it quite all right. It come back to reasonably good. I didn't do any further because there's so much combination down there. So I put, maintaining that way, I put the 2 more 4K wire on either side. And then I put the one kind of 1.2 millimeter K wire to the dorsal one on this dorsal small little fragment, go through down there, and maintaining this further displacement or reduction. And the cement come out. And after that, this is the check X-ray, and that's the result. We'll get it after 6 weeks' time, was already the count. So in a simple way, you can do this kind of fracture in a theater. This again is complete and displace the fracture down that way. Simpler way, keep the hand manipulation first with the traction, then with this K wire in this distal phalanx, continue traction down that way. Is a very gentle traction. If you do too much traction, this is very thin and flat. It will tear out. So got to be careful. You just gentle, continue traction, and then here is a displacement. This displacement dorsally and that displacement. This is proximally and that displacement distally. So first one I attack this one. So going down through the fracture, I put a 1.2 millimeter K wire going to display that way. It is in that direction, but ultimately is going to be bent and try to push it back this whole dorsal directions, rather extension way. Then I got a very good reduction. So that's the way I can kept it down that way. And this K wire first in, and then 4 month kilometer, then holding this those two fracture together with the target. This one I got to tell you again and again, you cannot crush it. You just hold it together gently, just like the soft tissue pressure. That's nothing else. Otherwise, you're going to crush it whole things. So after that, I put 1.2 millimeter K wire through the dorsal fragment, through the dorsal side to the volar fragment first. I will do this one. You can see the middle of the volar fragment that way. After that, I put another K wire, it's 1.2 millimeter K wire from the dorsal to the volar side. That's the way I just kept the two fragments together. And this maneuver got to be very careful, otherwise you're going to split the fragment. And you got to make sure that you are going down to the center point, otherwise you're going to rotate it. So there is a reasonably good reduction maintained with a crisscross-wise putting the K wire. And then put the cement on. And then this is that X-ray at the end of the theater, and that is the X-ray after a few months' time. Now, how you do this kind of split fracture, the shaft of middle phalanx with the Dupuytren's injury as well. So I exactly same way, put the finger down that way, give the traction on with this distal phalanx and this 2 millimeter osteotome. First I make an incision, then 2 millimeter. This is the incision I made it. It's only maximum 5 millimeter incision. Then rotate it up that way. Then gradually just lift it up very good. That's maneuver got to be very, very careful. And we can manage to elevate reasonably well. But you can see there is a bit of depression still down there. There's another instrument I have got, again, it's very thin, 2 millimeter. I use for this kind of bone elevator, periosteum elevator for the hand or metacarpal fracture, if I use any plate. So that one, sometimes I use it of this reduction for this phalanx. And that's the way I managed to reduce articular surface reasonably all right, though even though there is a bit of depression down there, but I have to accept that bit because of the combination down there. Then I put the 1 K wire through and through to this big polar fragment. Then I decided this time I put the screw this time. So I put the screw down there on 1.7 millimeter screw and 2 more screw down there. But I have done little wrong thing here. I'll tell you why. What? So you can see there's a reticular surface maintained very well, but that fragment is not well held with this screw. It should have been a bit longer. I felt later on it will be too late now. So that's what happened at the end of 3-4 months time. So it's still not that bad. So now it's a bit more difficult fracture. This one is quite a bit of combination down there, and head is at a T-type fracture with the rotation of the condyle, different direction. So again, if I'm going to open this fracture, I'll be really, really in trouble. So I try to avoid as much as I can with any kind of comminuted fracture the opening. So I do exactly the same way, bend the finger and just give it the traction on. This time I go to the neck of the middle phalanx. And then I put a small nick down there, put a 1.6 millimeter K-wire, try to elevate this displacement, which is rotated polar direction. So I try to do the things. When I try to do the things, problem was I was facing, this one is hitching down there, is not reducing that way. So you try to down that way. So I put another K-wire on the middle on that way. This is on the dorsal surface. Lateral view is the lateral side, like that way going there. Slowly, this one get to maneuver from this K-wire to gone down to that level. And then I managed to reduce that way. So this level going down today, it will take 2-3 minutes time to going down to that level. I managed to reduce that displacement reasonably that. You can see that way. So I took it out and it looks reasonably quite a good shape and good length. Then I put this intercondylar fracture. I put this 1.6 millimeter K-wire as usual. I put the cut end on this end. And then I put one cross K-wire to this spiral fracture. And then after this 2 K-wire, this is 2 K-wire done. Then I put the 1 K-wire in the neck and 2 K-wire in the shaft, one of the base of the middle phalanx, one of the shaft of the proximal phalanx, and then 1 more K-wire on the shaft of the middle phalanx. Then simple job is over. After that, we put cement on. But here, this 2 K-wire is coming from the other side, from the medial side, other side. So I bend it over on the dorsal surface so that I can incorporate with my cement to hold it better position. Otherwise, it will going to come out. So all this K-wire is incorporated with this 2 K-wire as well with the cement, so that it gives the better fixations. So that's that AB looks like. It's coming back from this radial side to the ulnar side, and this is that dorsum, lateral view dorsal surface. So that's the way I fix this kind of fracture, and that's that end of the operation. I'll take the traction off, and there's a post-op. This is the fixations, and there's more result we'll get it to that way. I don't know what the other people will do the things, but simple I feel is if I can do without any kind of opening, it gets a better result. But this is a young man about 25. He lives in London. He's a teacher of St. George's area. I don't know whether you know St. George's Hospital in London. It's a quite a good, very renowned hospital. And there they didn't give any kind of hope that this finger is going to move at all. It will be stiff like that way. So he lived somewhere in Bradford near my city. He came back Bradford Oral Infirmary, and they also did not give any hope. Then he came back to me, and I also did not give any hope. By this time, it's 2 weeks over. Nowhere he getting any hope, but he stick to me. So I said, well, I will try, because otherwise you're wasting your time. It's already 2 weeks over. Hey, wherever you go, you'll not be able to do more than 3 weeks time, then it is already done. So he stuck to me. So what I did exactly the same way. I bend the finger like that way, do the traction on as normal as it. And then I found that with the traction, it is not the reduction is called, except there's a bit of displacement, and that is a bit of depression still down there. So I just elevate that kind of proximal displacement, put even a K-wire in the joint and lift it up a bit. I managed to reduce that bit, and then I tried to Diphan's injury. I reduced it with this my 2 millimeter osteotomy, leave it like that way, and it is reasonably good kind of articular surface. There is a little bit of depression down there. I did not go too much because already 3 weeks when I started doing the operation. So I accepted that and put the cement on this with the 4K or like that. So that is the X-ray in the post-operative period. That is the looks like. That is the incision I made it, and that is that clinically how does it looks like during operation, after the operation. And that's that fixations, and that is that end of the 6 months time. He came back to Halifax and have an X-ray. There's a bit of depression on that, but he got a full movement of his finger. Fine. So as far as this phalanx concerns, that's fine.
Yes, I think we can have a little question and answers. I request other panelists to also switch on the video and as well as a microphone. Subhash, what we do is we use a just clamps where instead of using cement, we can put a clamp which can take crisscross wires, the connecting rod and the K-wire. Both are K-wires only. We clamp them together so that we can still adjust. If we are not happy at the end of the surgery, then we can still manipulate it, the fixator. So are you aware of that and your comments upon this? Because once you apply the cement and if there is any, if you're not happy with the fixation, there is no way you can undo it. Yeah.
That's right. Yeah, absolutely right. That's absolutely right. So you have to 100% make sure that what you're doing, that's why you need a bit concentration. And I usually do it because that clump, we have not got that kind of small little clump with a 1.6 millimeter K-wire to holding the clump, one thing. The clump is a very good idea, no doubt of that, because you can adjust it whenever you want to do the thing. Even in the clinic, you cannot adjust it. That's true. But as you say that, I am not, as you said, designated really hand surgeon and specialist. We have not got that kind of financial backing up of this kind of clump, small clump for that. We got a clump for femur, tibia, other thing like that, not the hand. So I had no choice to. But you're right.
Yes.
It is much. It is better.
Yeah, the advantage is you can even put a distractor, small distractors also available. We can apply that.
That's right.
Yeah. Pankaj, any question? Pankaj has got some question. Yes.
Yeah. I think an overwhelming presentation for me. I started off applying fixators on the finger during my residency almost 25 years ago, not knowing how to put fixators on the finger. And then spent next 20 years unlearning those, putting the fixator and then doing some complicated internal fixations. And only when I thought I was good at it, now I see your presentation of fantastic outcome of external fixations. Reminds me of my residency days with Dr. C.A. Tarwarkar. He was a great proponent of external fixation for the knee and the ankles. And he used to use these cement rods, plastic tubes filled with cement as external connecting rods, and reminded me of those. Though I have a few questions for you, since I do not use external fixators at all in my practice. I think our question answer sessions should generate good information for the audience. One is, how long do you keep these fixators? I mean, what are the parameters on which you decide, okay, this is the right time to take off the fixator and start mobilizing? What is the protocol that you follow?
Fine. Phalanx, maximum 5 weeks.
Okay.
Maximum. I come the metacarpal 6 weeks. After 5 weeks, if you do like that way, joint will be stiff, so completely. So if you join up 5 weeks, in my practice, I take the 5 weeks off and then start exercise. Now, joint will be stiff. I got a setup for the exercise of the patients. I tell the patients, bend your finger and every hour for 5 minutes. I said, whatever you do 18 hours a day, you spend 5 minutes for your hand. That's my patient instruction. And that 5 minutes, you put the other hand, if I can show my hand, put it down that way and see the palm and the nail. Each time you have to 1 millimeter down and hold it 1 minute. So it means 5 minutes, 5 times you do 5 millimeter down. And each time you do the things, and that's the way they get reasonably good movement. If you get a simple instruction, you don't need to go to physio. You get a look every hour, on the dot of the hour, 9 o'clock, 10 o'clock, 11 o'clock, you do 5 minutes for your hand. And each time I told them, you flex your hand with the other hand, with the palm of the hand. Your nail should be on the facing on the palm, on the base of the palm, so that you can measure it. Each time you 1 millimeter down and hold it for 1 minute and 5 minutes. So if they encourage the patient like that way, in a 4 or 5 weeks time, it is an early movement you should get it. It doesn't need a special physio.
Yes.
Sorry,
For all of us is it's not about only about the fixation. It's also a very diligent mobilization protocol in which the surgeon himself is involved, and the patient is not delegated to the mercy of the therapists.
No, I never send the patient to the physio. Actually, because physio has got a different kind of motivation. Physio has got an overall picture on that hand injury, which I don't drive in a highway. I just driving away a little bit of side lane. So I got my own idea. So I don't trust them, because many times it happened. What I say one thing, they say different thing, and patient get confused. Doc, which one right? Are you listening to you or listening to physio? So I was from the start with step patient every week. I bring it down to me. In my clinic is busy, no doubt, but every week I see the patients. You show me how much you have done it, and you just if you can encourage them, that's very good. I said the 5 minutes for your hand, and that they do very well. And you look after your hand. No physio, they have got their own mind and setup, and you got a own mind, your setup. Your colleague has got a different kind of mind and setup. Some other colleague has a different mind and setup. Each one has got their own idea. I'm not criticizing any other, but everybody has got their own way to do the things. Whichever I like it, I like to do that. And I know whether I failed or gained.
So I have one more question about neglected PIP fracture dislocation. That's how we see them more often. We see them quite less often as fresh injuries. We typically would see them anywhere after 3 weeks, even up to 4 to 5 months as first diagnosis. So what's your approach to such patients? Till what limit would you want to try the method that you described?
I will do as much as possible. I will try by close, as the is a K-wire manipulator. When I was a Metacarpal non, and I will show you that. I'm the man. I just see the X-ray on an image intensifier. I never see on the theater on the bone. That's the way I hardly open the fracture. It doesn't matter what. But at the same time, is a clinical picture of the presentation of the patient to the England or the Western world is different from the rest of the India. Because the Indian comes a bit late, because it's a huge country and it's a huge problem. So when it comes to you, it is a bit too late. That's the only thing. And there's financial problem, all other problems down there. But yes, I will try, because it's called ligamentum taxidy. If you want to K-wire down to the joint and slowly take a time and just to puncture hole here and there and damage that kind of fibrosis, and you can manage to release reasonably. Or as Shiva says, that you can put the external fixation.
I'm continuing the same question of Dr. Pankaj. My question, Subhash, how old neglected means? You show one case of about 2 weeks, you operated at the end of 3 weeks. Anything beyond that you have operated, and what the oldest one you have operated?
3 weeks.
3 weeks. Okay.
In this country, if it's a 3 weeks, you got £1 million sue, you'll be in the hospital. So nobody goes beyond that.
You have to unmute, Parag. Oh, you have to unmute. Yes.
Yeah. Sir, may I ask whether you do all these procedures under digital block or regional anesthesia?
No, regional anesthesia.
Okay.
Regional
You can do the
anesthesia.
regional anesthesia. Yeah.
Okay.
I got a good anesthesia. It takes only 10 minutes to do the brachial block.
Okay. And sir, after removal of the fixator, do you give any other finger splint, or you just start the mobilization?
Not the mobilization.
Okay. Sir, have you
No.
ever no other splint given?
No.
No. So
If the 5 weeks fracture doesn't heal,
yeah,
then it will not going to heal.
correct, sir. And sir, we have observed that your wires, they pass through the extensor apparatus of the or the dorsum of the finger. Have you
Yeah.
ever experienced any adhesions around the extensor tendons when like post-op during rehabilitation?
Extensor tendon doesn't cause that much problem. The flexor tendon is that more problematic thing. Extensor
Okay.
is very good tendon. It's very good. No, I did not face any problem with that kind of thing.
Okay, and even we have seen you have passed give a digital traction through nail apparatus. Have you ever encountered any nail issues in such cases?
Digital second, I couldn't follow
Yes,
that.
you have passed the wire through the nail apparatus to give a traction to the finger.
Yeah, so that nail is by the side the junction of the skin and the nail bed. But you are not going to go through the germinal layer. But you can go to this by the base of the distal phalanx. Then you need the help of the X-ray or with the neck of the middle phalanx.
Okay.
Depends on the size of the distal phalanx. You know, if you see the patient to patient, and different kind of length of the distal phalanx you get it. So when the distal phalanx is short, I usually go for either base or the neck.
Okay.
Yeah. So
But
this is what.
Yeah.
This was what I was talking about. This is Joshi, Dr. B.B. Joshi, you might have heard. Joshi's external stabilization system. This is not a very ideally done case, but this is what the immediate X-ray I could dig out from my collection and to show you. Here you can see that the K-wire is used as connecting rod and another K-wire passes through this. And this clamp is clamped with a nut which is inside. We're using Allen's key. So you can either distract or compress, or even you can apply a distractor over this and do the manipulation. Any comment on this? Yes.
No, that's very good. That's I think we got a systems like that when here also, not in my hospital, but in hand surgery on the other department as well. But problem is sometimes what was happened down there, you had to have a good alignment of the all 4 or 5 K-wire.
Yeah.
Otherwise, you have to have a different kind of hole or the clump. You have to be careful when you put the K-wire.
Yes.
You have to have exact same alignment.
Yes.
That's you got to be careful.
Yes.
Unless you go slightly 1 millimeter, 2 millimeter deviations, then it will create a big problem. Otherwise, you have a multi-hole clump.
Yes. Okay.
But
Yeah,
clump is very good.
Yes.
Clump is very good.
Yes.
But I use the cement because
it's available free of cost. It's expired cement.
Yeah, they will throw it away. I say, keep it for me.
Yeah.
And as you say that there is a bit of drawback if it is not fully reduced, or if anything happened, you got to be you cannot come out from there. But I usually 100% make sure that I'm happy before putting the clump.
Yes.
Before putting that.
I was working in Starbridge. Even my consultant used to take the expired cement, and whatever the cement was there, that he used to make a ball out of that, and he used to lit up his fire in the house using that cement ball. So these are all the additional uses which we can use for the cement. Anyway, I think you can share your screen and continue with the talk. We'll get back to you with more questions in due course of time. You have to share again, sir.
Okay.
Yes. Meanwhile, we had got Dr. Abhijeet Wahegaonkar for a short time. We have lost him again. Yes. Okay, sir. Yeah, we can see the screen.
Fine. Fracture neck of fifth metacarpal. So this is kind of fracture we usually get here. I mean, possibly you also everywhere, and it is kind of not a very, it's a very common fracture, but it's a neglected fracture. Here is a people, well, it's a third fracture. It means the guy who just punched some other people, mainly happened to the 12 o'clock at night when this pub closed about 11 o'clock here. And then all the young guys fight each other and come back with this kind of fracture, or is a boxing chap who's either is punching the sandbag or somebody. So not many people interested do this kind of things, but when they get displaced, sometimes they do. But if you treat conservatively, which is normally 90% of usually treat, but sometimes you get displaced way to heal it as malunited. This patient came to me, and he's a ordinary laborer guy. He said, Mr. Halder, I cannot hold any kind of hammer or tools because this head of the fifth metacarpal is just underneath the skin and it's developing a scar. So you got to do something. So you can realize that even though this looks like reasonably all right, but if you do the true lateral view, it's quite far, far away from there. So you have to do the osteotomy, and it's quite a bit of a big problem rather than solving it initially. This fracture, conventional way to treat that integrate wire, usually have a 2 wire is better, then you don't need any kind of rotational problem. Otherwise, 1 wire you need a plaster to put it on. And sometimes when you get a very thin medullary cavity, it's very difficult to put the 2 wire as well. So most of the time people put the 1 kind of wire. That's maintained a good reduction, but then they incorporate some kind of plaster you need for that. But other thing is the most sophisticated operation is plating, and all big hand surgical department, they do is very good things. But problem is that I did few cases also, but everyone, in my case, 100% had to take the plate out because it's a subcutaneous. It's so much, little bit of bang or tender, it's always causing the problem. And when you take it out, 90% time is head broken down there. So take the plate out and head out, leaving that screw inside. And that's not very good ideal also. So that's a real problem with the plating of these kind of things. So this kind of fracture, you can see a bit of combination down there. Pattern of the fracture is kind of distal fragment is got volar displacement with shortening, and the proximal fragment go dorsal displacement. And that's the way this 90% fracture happened, this kind of pattern fracture. How I usually fix them that way, I usually fix a different way. I just pulling a traction, reduce it like that way. This is the reduction of the traction. And then I put this kind of similar kind of simple traction. Sometimes I put, sometimes I don't put also. And then what happened? Then I put a 1K wire, 1.6K wire, just at this head and neck junction down there, the middle puncture hole down there, and put it down there and go through head of the fifth and the fourth metacarpal. Is that the 1K wire is giving you reduction of the distal phalanx as well as length of the distal phalanx. Now question is that how it's going to do this dorsal phalanx, proximal part. Proximal part, now the dorsal displacement. So I put another K wire 1.6, little nick down there and go hit that cortex on the ulnar side. On that, this is that kind of displacement. So I'll go this hitting ulnar side of the spike, and over the hand you go over the spiky bone, just over the spiky bone, but underneath the extensor tendon. You put a finger down there, you feel the tendon rolling over there. Or you can feel also if your K wire go over the tendon, then you can feel that your K wire also around that. So you got to be careful from this point. And then just lift a bit up a bit because the foot metacarpal slightly down. So just lift it up a bit and hit that foot metacarpal and go through and through. So this one go through and through, and this one go on the top of this spine. That's why we keep the depression and reduce the fracture of the proximal fragment. That's the only simple, these 2 KY, it takes only 10 minutes to do the job. And that's all, everything you have done it. So that's what clinically looks like, just slightly, one is one level, this is slightly higher level, and then traction off. This is another fracture, exactly similar type that way. I go to more details, I go to reduced love that way. This is the finger looked like that way. It came back a few weeks later, so I had to put a bit more kind of pressure down there to reduce it. This is a KY on the head and neck of the 4th and 5th metacarpal. I put a small knife to nick down there, then on KY, just go through and through the head and neck of the 4th and 5th metacarpal, 5th and 4th metacarpal. That's the way is distal fragment fixed. And then another small incision slightly dorsal to the first KY. And then with the hand, you got to go, not with the drill, with the hand, you got to go hit that bone and then rolled over and go over the spike, but underneath the extensor tendon. Once you go down there, then fix the 4th metacarpal and sort of come out. And then bend the wire. And this just protect the end of the wire with this some kind of silicone tube and bandage it up. Doesn't need any plaster, doesn't need anything. So that is the fracture, that is the fixation, and that is the result you will get it. Doesn't need anything, just 10-minute job. Is again, I'm going to say that one of these fracture reduced. Only thing you have to take it down theater, reduce from that way. Again, it has not been reduced fully, that traction. I have to put a bit of pressure over there at the end of the spike and to reduce down that dorsal displacement. Again, put a knife down there, make an incision, and then go through and through to 5th metacarpal to 4th metacarpal. Then coming back to this neck fracture is again putting the KY down there with the hand. You just go over the spiky bone, but underneath the extensor tendon and go through the 4th metacarpal inside. If you got any doubt that this is swollen hand, if you got any doubt that you cannot feel the extensor tendon, just let me a little nick down there, and you can see the pale white extensor tendon down there. If it's extensor tendon down there, you must see that your KY on the top. You know that thing. So one extensor tendon is quite superficial. You can see down there. If any swollen hand or any kind of doubt, you must not put the KY underneath on the top of these extensor tendon. Very easy way to do the thing. But most of the time, you can roll that extensor tendon over the 5th metacarpal. Then I have to fix one more KY because there's a base of the 4th metacarpal also broken. So that's the only thing you need. Then bend the KY, and this thing happened. But I don't think I've got a check X down there, because what happened is I'm interested in that, but my register, they don't bother that much. You just take that wire out and send the patient home. Thank you very much. They don't have a check X-ray all the times. Anyway, so different kind of things in the transverse fracture. This is a transverse fracture, wide displacement, full diameter displacement. We'll do the exactly same, but it's slightly different. Reduce the fracture the same way, go through the 4th, 5th to 4th metacarpal exactly the same as through and through. But this time, you got to go through and through both, because the transverse fracture, you cannot go on the top, there is no spike. You got to through and through both, and then another third KY will go on the proximally to the 2nd KY. So this kind of not on the top on there as we did the first time, is spiky one, is you go through and through, and that like that way. So this is that original X-ray, this is a fixation, and that's the end of the result. Only 3 KY. So that's the way I fix the 5th metacarpal. When you have got a kind of 4th and 5th metacarpal together, find that way, and bit of combination down there, exactly similar way I'll do that thing. There is no difference will be. Just reduce the fracture, put the first KY through and through the 5th metacarpal, because this is broken as well. This one again is spiky bone, top of the spiky bone, below the extensor tendon and through the 4th metacarpal. and then go through and through fourth and fifth metacarpal. And that is the lateral view. And that is that X-ray after 6 months, possibly I took it out and have an X-ray. So there is no difference at all compared to the other carpal bone, even though because of two bone broken. So this is a young boy, about 13-year-old. He fell from the bike, and now this kind of injury sustained, a split fracture, split head, T-type of fracture is happening. It took about 2 weeks to come back to my clinic. So now what's happening, I reduced the fracture, I manipulated with the thumb on the polar side, managed to put it back. Then I put the K-wire through this head through, and then that way, and try to lift it up and without further displacement. And you can see this is a curvature of the K-wire to holding together. So that's the way I fixed it up. And then after check X-ray of the few weeks time, when they take this fixator off a few months time, then 1 year, it has not damaged his growth of the fifth metacarpal any further. He did reasonably well. Now this, I got a story, this one. This middle, 35-year-old gentleman had a fracture like that way, it's a dislocation. One of my colleagues, we got a theater system here, and I have got one theater, they have got one theater. I got every week one theater, especially for my humerus, and I can manage to do one humerus and one small little cases. But when I came to theater and I'm doing already started, other side of theater, consultant did the job, and then as a register to do this one, and he already left the theater. When the register was trying to reduce it, he could not do the things. He called the consultant back again. He could not do the thing also. So he asked me, Ms. Subhash, can you do something for this? But I was already started my case. So I had to leave that one and come back here. So how I do the things is because I was not that pleased, because I have been told in the beginning before my starting the case. But my case is already under. So I came back to his theater, and I pull it up with my manual hand because I didn't have that much time to put the K-wire, that thing. I have to finish it as much as you can. Then I put the K-wire. Now you can see that my K-wire gone down from the ulnar side to the radial side to the head. And then I try to rotate it back and back. Now you can see the positions of my K-wire from there to there. It took me nearly 3 to 4 minutes time to bring it back from that level to that level to that level. So if I'm rushing that way, I may be splitting that one, because that is that joint is hitching down there. You got to be careful. So I'm taking a bit of time, so going back slowly to bring it back to the normal positions, putting the K1 one simple K-wire. Once I got the reduction, then a simple job, exactly the same thing. One K-wire pass through and through, and other K-wire, because this is a spiky bone down there, other K-wire pass on the top of the spiky bone and through the fourth metacarpal. And that's the finishing, and it came out. And that's the original X-ray. There's the X-ray after 6 months of the operation. So you can do this, even a little complicated operation, simple. So key points is that these kind of fixations, the initially fracture reduced by gentle traction applied manually, then 1.6 kilometer inserted the head and fourth and fifth metacarpal, as I said, this one. Then another second K-wire is go through on the top of the spike and through the fourth metacarpal. But you must see the K-wire passage extensor tendon can be palpable. If it's not palpable, you must have a little nick and feel there is a tendon on the top of the K-wire. So now coming back to the spinal fracture of the shaft of the metacarpal. Again, this is not a very big job. Many center will do, because he has got some rotational problem. That's why I came back to theater to fix it up. when you try to fix it up, the plate is fine, but when you put the K wire down, that what happened? When you put the K wire, that one is fine. When you hit the K wire, they get displaced. And that's happening here. So when this, my resistor was trying to put the K wire down there, and then when you put the K wire the other side, it got further displaced. So you're trying to put another K wire. And I was thinking that that is not really acceptable because you displace the fracture compared to the weight of what you have reduced. That's not a good way to do the thing. So what's happening here, if I can explain to my junior kind of surgeons, if they listen to me, please. So what's happening here, when this fragment is moving out, so idea will be how we can stop moving this fragment. If we can stop moving this fragment, then you can put the K wire in. So only way to stop this fragment to move, pushing out, just put the one K wire near to the base, near to the fracture. Because this is got the ligament attached together on the carpal bone, so the metacarpal bone. So if I got the one K wire near to that one, is very little movement down there, which I did that way. There is not much movement down there and down that way. So that way, now we have fixed this fracture. That's under that way. This one is now fixed. So if I'm going to have another K wire down there, so you will not move. That is a box now. So you will not move any further. I'm going to move not that way. Now I'm going to do it. So my message, possibly, I don't know how that with the junior surgeons, so whenever fracture like that way comes, which one going to displace, you fixed up either proximally or distally this one, so make it more stable. Once you have the stable fracture, then you can put as many K wire as you want without further displacement. So good with that. The simple, that kind of message, if I can give it to them. So that's why it's holding nicely, reduction. Exactly same thing happened, there's other way around. Now when I'm going to put this K wire from there to down that direction, is going to displace that way. So how can you avoid that? So avoid that, I'm going to put this distal fragment, I got to little bit make it more stable. So I got to put one K wire from the fifth metacarpal to the fourth metacarpal. So here is a joint down there, here the ligament down there, will not move that fast. So if I can do that way, and this fragment is much stable now, hardly any move down there. So once I make the fracture stable and ask my assistant to just keep it more pressure on that, then you can put this K wire easily without any further displacement. You can say just simply put the through and through K wire. Once you without further displacement, but you can see that if you are doing a point of K wire down there, it's going to displace. Even you got the heat from there to there, it's going to displace. So now once you got this one, then put the one interfracture K wire down that way. No further displacement of the distal phalanx. And then this square out, and then one K wire in the base of the fifth metacarpal. That's the job you have done it. So that's the things you got to know, that you got to do the things, and at the end you got a good result. So simple kind of information is that, I don't know how much is that. This one, as because it is mobile, you fix it up, you reduce the fracture, fix it up near to this kind of joint, and you can make it more stable, then you can do the K wire without further displacement. So again, is a fracture at the same level, is an unstable fracture. Many center will do either K wire in the integrated way, or many center will do simple plating, those who are high profile department of the hand surgery. But I not very keen on that kind of open things. And I reduce the fracture, and I put this to K wire like that way, keeping the more traction, because the transverse fracture is very mobile. Again, to make the distal fragment stable, so I put the one K wire through and through all fragment, so that these two metacarpal much more stable now. Is if I put the one K wire now here, you're not going to move any further. What I'm going to prove that. So after doing that, I fixed that proximal fragment as well near to the joint, which is one square to these fit to the fourth metacarpal and the third metacarpal. That way. So once you fix these two either way, this is two proximal and distal can be more stable, then you can put this other two KY on the either proximal and distal without any problem. And then as you put the one, there is no further displacement. So that's that usually I fix that kind of metacarpal fracture. Before fixing the fracture stateway, I make that fragment stable first. So this is the fixation, and there's a taking out after a few months' time. Now again, is that's why there is a different two kind of slightly proximal fracture. So I'm trying to fracture, put the KY down through the fracture to that way. It's going to displace that direction. You can see that once I hit that cortex, it's displacing that way. How can I prevent that bit? First KY. So I put this kind of, it's called the stabilizing QR. I put on the radial side, I put the 1.6 KY, but counteraction on that way, so that it doesn't displace any further. Sorry, I put that 1 KY on the side now. Now it's making more stable. I can go through this shaft of the fifth metacarpal to the carpal bone. Once I put that way, then I put another KY on the shaft now. Now its problem will be the fourth metacarpal. That's going to displace. Again, similar way, I again stabilizing KY on the fourth metacarpal, holding that way so that it does not go any further displacement. So I put it down that way. That's another way you can stop displacement the fracture or the direction. So once you do the second KY and you finish it up, then I put the 1.2 millimeter another KY through and through the fracture side of the fifth metacarpal. Now this Bennett fracture or Ronald type of fracture, we don't know, but it is quite displaced fracture. Is also a bit rotated. So I was finding difficulty. Normally what you do, push your thumb down that way, thumb on the base of things and push it on the adduction positions, but there is a kind of displacement of the this kind of this fracture fragment, sorry, and we had to reduce that one. What I did, I put 1 KY down that way. I put through the fracture and try to manipulate as much as you can. So I did the to and fro movement to this KY, and I managed to reduce reasonably all right. So that kind of positions I managed to do with this on KY with it putting one start from there, going that direction, going to the on the ulnar side and then bring back to the radial side again. Somehow we managed to reasonably quite good positions of the particular surface of the first metacarpal bone. And then once you go down that way, holding them that way, first you put another kind of KY, and with the second KY will go through this base of the shaft of the first metacarpal to the carpal bone, and this as normal is another KY go first metacarpal to the base of the second metacarpal. So that's normal thing. As long as you can maintain the articular surface of this fragment and any further rotation. So that's the way I sometimes reduce the fracture rather than opening up and fix it. That's a fixation on that. There's another fracture is a bit complex more, and also fracture trapezium. One of my colleagues, hand surgeon friends, and he did the scans, also the things. Now left it to me to sort it out, but I have no clue what to do. So I'll tell the patient I'll do the simplest way, because he will going to have a little bit of arthritis anyway. So I just pulled it up, and it trapezium fracture reduced quite reasonably well when you push it in place. So that's the trapezium is reduced all right, because that's kind of ligament attached down there. So that's holding that way. So first, and I also give a bit of pressure over this blunt end of the one of the osteotomy. So I put the one KY down there, normally as a Bennett fracture, what you fix it up that way, the same way. And this came out because this is, as long as it doesn't move thumbs, this trapezium fracture will not move because there's a ligament down there. So that's the way we fix it up, and that's the way after 1 year is a result of that. There's a bit of depression on that, but otherwise he's doing fine. So now the non-union. Now this is a young man in our hospital. He's a son of a matron. He's taking 1 year off from after the school. He's going to have a career in medicine. And that is the result at the end of 6 months. And he's having a pain. He's working as an ECG technician. And the mom came back to me, said, Mr. Halder, he cannot go to medicine with this kind of hand. So I brought him back to my clinic, and then I said that, well, I'll try to do it the simplest way if I can. Otherwise, you need a plate or bone graft, which many people do. So I took the theater. I just put the one KY down that way. I tried to reduce the fracture. I put the KY with the drill because it's already done that way. So I managed to go the other side. And from there, with the hand, with the pulling of the thumb, I slowly, this is the pulling of my thumb, and managed to manipulate this displacement of the non-union. Reasonably good position with some destruction down there, you can see. So after having this reduction, I put the one K wire by the side of the fracture or non-union, and then another K wire on the proximal side of the K wire. Then another side on either side. The fourth K wire, again, this is my favorite cement. I put it down that direction. I can say there's a bit of traction. I put it down that way. I left it for 6 weeks, and I took it out. And he didn't come to the clinic. My registers discharged him from the clinic, and I saw him sometimes in the corridor. I said that, young man, what's happening to your hand? I said, Mr. Halder, I'm working all right. And I said, come back and have an X-ray. So I just pestered him to have an X-ray. This is the X-ray after 1 year, and he's doing fine. So yes, non-union, sorry.
Yeah, you said non-union. How many months are it's? How old was this non-union?
It's a 6 weeks, 6 months.
6 months old. Okay, yeah. 6 months old. Just by stabilization, do you think it was a united? You got a union. I know this case is something different, but
I don't know. I don't know.
6 months non-union without bone grafting, with so much of gap in between.
Well, you can see that there is you can see how much amount of kind of bone formation on the other side also.
Yeah.
Pseudocallus formation. Okay. So it's like that. Yeah. Well, that's happening. That's why I couldn't do anything. I had to put the KY down there to break the bone. Okay. There's a pseudocallus down there. It's a quite big callus down the other side.
Yeah. Okay.
Yeah, but that's I do work. Because I'll show you the another one also. You'll be surprised. That's why I don't drive in a highway. I just put it aside away. What are you going to do this one? This is quite a few months old also. Now, should I ask you before I do anything? I dare to do anything.
Yeah, I would normally open, freshen up. If it is 3 months old, then I'll put a wire retrograde from the base of this fourth metacarpal and fifth metacarpal. That is bouquet technique. Multiple small wires of 1 millimeter is passed, which is bent, and so that's how I treat them. Anyway, let me see how we are done. Any other option, Dr. Abhijeet? We have other people also. Let's take their opinion.
Well, I think a test book will be showing that either for the plate and the bone graft, possibly.
Yes. Dr. Lad?
Yeah. So if the patient is asymptomatic, the only problem here, fourth and fifth metacarpal, is reduced grip strength and reduced metacarpal height. So I would personally feel that doing open reduction and only plating and achieving compression at the fracture site will give us good healing. So my choice would be plating.
Yes, Pankaj, you have to
Uh,
unmute. Pankaj, yeah.
yeah, if you want a short answer from me, I would plate this for a variety of reasons.
Yeah,
Uh,
I'm sure that is the norm. That is the book. This book
yeah,
says.
yeah, absolutely, absolutely. I think one of the fantastic things which Dr. Halder is underlining is the forgotten art of close reductions and percutaneous reductions of the fractures. Ultimately, we need to reduce these fractures and stabilize. Methods can be many, and we have a lot of choices of methods. However, when I see a fourth metacarpal with such narrow medullary canal, I'm a little wary of doing anything intramedullary. So either I would do something percutaneous or I would do a open reduction and internal fixation.
Okay, Abhijeet, let's take the another opinion. Dr. Abhijeet Wahegaonkar is the, yeah.
Good evening, everyone. First off, I'm very sorry for the delay in joining. Had an emergency. Yes, I think when we talk about such fractures, and there is always an out of the box thinking, and we have evidence-based medicine versus eminence-based and experience-based medicine. In my humble opinion, in my short experience, when you have two adjacent metacarpals having a transverse metacarpal fracture, with perhaps a rotational and a shortening and an angular deformity. These are inherently unstable fractures. I would perhaps plate these fractures and mobilize early, but I would fully concede that there are multiple ways by which this can be done. And let's hear what Dr. Haldar has to show us. Thank you.
Yes.
As I said, that also depend. Perhaps you're absolutely right. It is supposed to be plating, and this patient, as I said, that booked for plating by other theater. As I say that I always have my one theater afternoon. I come back to my theater, and that idiot register. I would say idiot in a nice way, idiot, because he's a very nice guy. He said that he's a 7-year register. He's about to be a consultant. He's very good. He's supposed to do that one at the end of his theater, but in our hospital, what happened? Every Friday afternoon, they have got kind of teaching session. They had to go and do the teaching some other places. So he didn't have that much time. He left that theater and gone, and this patient is already in theater, other side of the theater, not my theater. So I came to theater, and then the sister said, "Do you know, Mr. Halder, one patient left to you?" I said, "I didn't know, but customary here, I don't know, I'm sure it is here, that if I leave any patient to somebody else, I usually ring them, the Mr. Such and such, can you sort out this patient? I couldn't do the things, but nobody has rang me. So that was a bit unusual in this kind of society. So I didn't like that at all. So my what we call brain was not 100% working because of this kind of things. So I came to see theater, I saw the patient, I said, look, I've not got that much time. I'll do simplest way. You come for plating, I have not time to do the plating, it will take at least 1 hour, which otherwise I have to cancel my other patients, which I already promised him to do today, which I cannot do the things. Otherwise, I will cancel you, or I can do some things. I will try to do some things if I can't do, otherwise I'll bring him back again. So this kind of things will happen. So what I'm trying to do here. So what happened? I pull it down that way. I put the 1K wire. It's a 2 millimeter K wire down there. As you can see the gap down there. And keep pulling. Slowly, sustained way. I just managed to reduce that way. It took 5 minutes time, but I somehow managed it. And that is that from this reduction to that reduction. Once I have that reductions, and I just left it without that, let's see how much is stable. I took the K wire out, it looks stable. Once I get the rest over out, I fix it with this 2K wire. and the 3 K-wire. And my favorite cement, I put it on. So this is the bridge this side, this is the bridge this side. So left like that way. And that's a lateral, and that's the result. That's a few weeks or few months in theater. And that's the result after 4 months. So yes, this is a completely norm to have a plating, but sometimes if you get the 100% reduction and you can fix well, it can be done. I'm going to feel like that way. So yes, people doesn't like me because I do something different. I always work in a slightly sideways, but I show my result. Either believe me or not, that's the all I do. So that's, I think I'll leave it for the metacarpal and this scaphoid. It's a thing like that. I will go to more controversial scaphoid.
Okay. Parag, or somebody has any question?
No,
We can
sir.
have a few questions now about metacarpal, because we are now changing over to the scaphoid fracture. So before that, we can have some questions.
I have a couple of comments, and you can consider them questions as well.
Yes.
One of the problems of traction in extension for metacarpals is difficulty in assessing the rotations. So for all the young colleagues who are seeing this presentation, do not look at these as simpler options. I would say percutaneous fixations require higher level of skill than does open reduction under direct vision and under palpation. So my question to you, Dr. Halder, is that are you telling your assistants to hold the finger in a particular rotation to ensure that you are not getting rotational deformities?
Yeah. Usually you see that my traction the finger, all the nail bed, all the fingers will be exactly the same level.
Yes.
If you are applying traction to multiple fingers, do you use the same technique for all the fingers, or they hold it with the hand?
Yeah, I said that 2 fingers, I apply the 2 fingers. That's a much better way to all the fingers in same rotation and same way from the exposure to the resistant hand.
Yes.
And that's the way you go. And also, once you have a little bit 1 or 2 K-wire stable, then you can flex your finger, and then you can see whether there is any kind of rotational problem before permanently fixed up.
Yes.
So you can fix it. So yes, as long as you can maintain the rotation, that's all right. But that is a good of this K-wire traction. So you can see the nail bed compared to the other finger as well.
Okay. Abhijeet or Parag, do you have any questions?
No, sir. Let us hear from scaphoid.
Yes. Subhash, I have got a few questions which I have received on my, you have answered many of them, but even then I'll take them because they were sent little earlier, which I probably missed it. What is your opinion about using plates in finger, the phalangeal and metacarpal fractures? Have you used it, or you are not using? Or
I use some screw. I use some kind of phalanxes. I regret it all the times because you have to take it out all, and it's so fiddling. 1.23 and 7 millimeter screw. It's such a small little things, and sometimes it's very difficult to apply for that and measuring from that.
Okay.
It's very difficult. Very difficult.
Yes. Another question is finger fractures. Do you do in brachial plexus block or the ring block?
No, not ring block. The brachial plexus.
Okay. Both these questions are from a plastic surgeon, Dr. Ajinkya Ukkarande. I'm glad that plastic surgeon people are also watching this your talk. Then Dr. V.N. Gaur from Delhi has asked.
Here, plastic surgeon taken over the hand now. You know that.
Yeah, correct. When do you allow finger movements? Dr. V.N. Gaur has asked. I think you said it is 5 weeks.
Yeah.
Yeah.
It's 5 weeks. As soon as you take the K-wire out, you start moving.
Okay. The similar question he has asked again. How long do you keep the K-wires? Again, it is 5 weeks. Yes. Okay. You can share.
Metacarpal 6 weeks.
Okay. Okay. Fine. Yeah, you can. Yes, Abhijeet has a question.
Yeah, so Dr. Halder, this question is regarding the Valent anesthesia, which, I think is a very popular technique and it has originated from Canada. So my question to you is, do you use Valent anesthesia? Do you prefer to do these fractures under wide local and awake anesthesia so that you can, look for the rotational alignment and confirm that the fixation is stable and so on and so forth?
Before that, Abhijeet, I will ask you to enumerate about Valent anesthesia because, yeah,
So,
it is a new terminology even for me.
certainly, sir. So Valent is basically something that was introduced by Professor Don Lalonde from Canada. And the acronym stands for Wide Awake Local Anesthesia and No Tourniquet. And what essentially is done is it's like tumescent anesthesia, where the anesthetic drug is mixed or diluted with saline and adrenaline, and then it is injected subcutaneously and gives very good anesthesia. So all finger movements or all joint movements are preserved, and surgery can be performed in a relatively bloodless field without using a tourniquet. And more hand surgeons are using this technique, especially for metacarpal and phalangeal fractures or tendon surgery to verify the outcome on table.
Okay.
So,
Yeah. Yes, Subhash, your
Yeah,
answer.
no, we have not got that thing. I've got a brachial block. I've got a particular anesthetist. It's very, very good. He just give the block and I do the operation. I don't use the tourniquet.
Yes.
But
Abhijeet, yes. Abhijeet,
I
my
can see.
question is, do you give the anesthesia yourself or your anesthetist gives that block?
So good question. To be very honest, I do not use it in my clinical practice, but people, especially, if you hear Don Lalonde, he gives it himself. Most of the surgeons would administer the anesthesia themselves. It takes about 30 minutes for the anesthesia to act. I think Pankaj and Parag have quite some experience using Valent in India, so maybe they can enlighten us regarding
Yeah.
this.
Parag,
Yes.
yes.
So most of the carpal tunnel, trigger finger or decurvance release, and some of the single finger extensor tendon injuries beyond the wrist level, I usually prefer Valent anesthesia. And in the recovery room, I give the anesthesia. And then once the patient is shifted into the OR, painting, draping, scrubbing is going to take at least 25 to 30 minutes. I keep the tourniquet in the arm, but since last 6 months now, I'm quite familiar with the technique, and practically I don't raise the tourniquet at all. But
Okay.
I don't have any experience in, I have not used it for fixation of the hand fractures. I've used it for the soft tissue surgeries.
Okay. How it is different from wrist block?
The hemostasis achieved by Valent is that is the only difference as per the wrist block, because
Okay.
here we add adrenaline.
Adrenaline, yes.
Yeah, so in wrist block we use plain lignocaine with bupivacaine. That is
Okay. Yes, Abhijeet.
I think the essential difference is that in wrist block, you go after the nerves. So you would block the median nerve, the ulnar nerve, the dorsal sensory branch of the ulnar nerve, and the radial sensory branch. So you're infiltrating around the nerves. Whereas in this tumescent anesthesia or the Valent anesthesia, you just inject subcutaneously. So that is one of the most important differences. And like Parag rightly said, besides the anesthesia, you have very good a bloodless plane or a bloodless field because of the effect of adrenaline. Yes, Pankaj.
Yes, Pankaj.
Yeah, I do a fair bit of fracture fixation under Valent, right from distal radius to scaphoid to PIP joint fracture dislocations, metacarpal platings, mallet fingers, extensor tendon injuries, flexor tendon injuries, almost everything. Not that I definitely prefer this method, but this is one thing which I have tried in almost 65, 70 surgeries over last couple of years. One, it has a very distinct advantage of checking mobilization and rotational alignments on the table. Of course, there are some disadvantages. Whenever we are attempting close reduction of the fractures in the phalanges and the metacarpals, the deforming forces are coming from the forearm, which are not paralyzed with this anesthesia. And with an anxious patient, the close reduction can sometimes be difficult. So you really need to talk your patient into anesthesia here. To the question about the difference between the wrist block and Valent. In wrist block, as Abhijeet said, we go after the nerves. When we are blocking the nerves, it essentially leads to vasodilatation distally. And then if you're giving a wrist block and not using tourniquet, you're actually operating in a very bloody field. The advantage of Valent is you can get the same field block, a very dense anesthesia, but with advantage of adrenaline, whereby you actually need not don't feel the need to use tourniquet. So for me, it's either a brachial block with tourniquet or Valent.
Okay.
Or if I'm operating on the finger, then I might give a wrist block.
Okay. Okay. Yes, Dr. Halder, you can start sharing the screen and proceed with the scaphoid. Nice to hear about the Valent block, because even for me, it's a new thing which I heard today.
In this country, we don't do that much, except that local anesthesia with some kind of digital block and other things. But otherwise, we get anesthetic because the litigation problem quite high.
Yes.
Anesthetic has got taken over that bit.
You have to start sharing the screen. Yes.
Fine. Scaphoid fracture. Most of the fracture I do fix with the minimal invasive methods. Like this kind of fracture, I try to do by as closed as possible. But when you fracture like that way, that's a different way to open it up. So I just do slightly different way. I do it in the same way, but it's a different technique. As normally everybody does, I put that people the wrist and put that wrist on a, it's called this bell band, because the section, the crepe band is on the top of the bit of flex of the rather extension of the wrist, and this is the position on that way. What I do here, I put the one K wire just at the level of the distal end or pole of the scaphoid, and put the one of the K wire down there. When my pain is in my hand, I just put a bit of mark on the wrist on that way, the level on that way. Then another K wire, I put 5 millimeter down distal to the pole of the scaphoid, and I put another mark down there. So that's the way it's 2 mark down there. And the one is that this is distal pole, and that is that 5 millimeter away from the distal pole. Then another K wire, I put it on the top, the axis of the scaphoid, and put another K wire down there and made a mark on that. So that's the way it will be. This is that screw should be going down that direction. So that's the way I made a bit of incision down there, and I put this K wire, scaphoid K wire down to the lateral or the radial side of the distal pole, and try to hit. Whenever this is my practice, before putting anything, I must stop the K wire at the fracture level. That's every fracture I fix it up. Before I pushing down further, I don't make any false hole on the distal or proximal. I got to stop every single fracture, not only scaphoid, either humerus radius or tibia. I got to stop it that way. And then I see that my reduction right, and then see that my level also where I'm going to go, my direction is right. My aim is down as much maximum amount of mass of the tissue, the proximal fragment, I get it. So that's the way I go to the scaphoid view. And then I first push forward and go as proximal as possible. So after that, I measure it with another K wire. It's a subtraction method. And then scaphoid drill, put it down, come back to screw like this way. So that's the way I do that to me. And that's a post-op, that's a 4 months after the operation. And that's a multifragmentary scaphoid is a young patients, like 25-year-old. And you can do that, there's quite a bit of discourse bone. And it came back to clinic in a few weeks' time. To be and position for an image intensify the thumb pulling. I put the thumb down that way, but still you can see there is kind of displacement of the fracture down that way, and also there's a humpback deformity down there. So I got to reduce that one. What I put the 1 KY down there, and 1.6 KY is pushing this one different direction. I managed to reduce it reasonably okay. That is that reduction, and this some humpback deformity is improved. Then I put that scaphoid KY and supposed to go that directions, and it's supposed to go that direction, but it's gone away from there. But I still accept it and put it down that way, and screw, put the proper length of the screw, put it on, and came out. So I didn't have that X-ray because the patient gone to some other hospital. Now this 35-year-old male patient, conservative done. These are 9 months after the conservative treatment. So should I stop it now there? Is anybody doing anything else? I'm going to fix it up and reduce it up.
Yeah, I think we also do the same thing or a similar thing. Anybody wants to comment? Hello? Yes, Parag.
Yeah. So this is sir. I assume this is an acute fracture, right?
Yeah, some acute and little delayed fracture also.
Because the X-ray shows proximal. I mean, the distal part of the fracture is the. I mean, it looks little. The shadow on the X-ray looks little hypervascular. I mean, hyperlucent. So I would consider, of course, open reduction and internal fixation. But if this is more than a month old, then I'm worried about the vascularity of the fragment as per the X-ray.
Absolutely right. That's a 39 months old, as I showed you. This particular one.
Okay.
Oh, this was the different. That was the different.
No,
X-ray.
this is, I started sharing the screen.
Oh.
Similar case.
Okay.
Yes.
So
okay.
if this is more than a month old fracture, I would consider MRI with CT cut to prove the vascularity in the fragment, and then I would consider open reduction and bone grafting and fixation.
You do the vascular bone graft?
No, sir. I would prefer a bone graft from the distal end radius.
Yeah, cancellous bone graft.
Yes, sir. Cancellous bone graft.
Yes. Okay, Subhash, this is a similar case. You can see there is a distal radial fracture and also the scaphoid fracture. You can see there is a small comminution also in the scaphoid. So I probably we all treat in the similar way because I learned this from Dr. Sudhir Warrior and Hemant Patankar. I normally pass 2 guide wires that will fix the fracture. So you can see that I have passed 2 guide wires. Once it is in the bone, the other guide wire prevent the spinning of the bone, especially if it is comminuted. Yeah, then true. I pass the drill. There is a cannulated drill. Yeah, then the screw is passed. Are you happy with the reduction, sir? Subhash?
Yeah, that's fine. Yeah, that's good.
Yes, and I take the X-rays and different views because whatever all the views are possible, I take and confirm that they are inside because it sometimes we miss that track because of the bad X-ray view. And this patient this patient incidentally had a distal radial fracture which I have just fixed with K wires. And this is the small incision with single stitch, and this is the K wires. This is a small Jess clamp I have designed which is round in shape so that it won't get the tip of the K wire doesn't get caught in the dressing. Otherwise, sometimes it is possible that when we change the dressing, the assistant pulls that out.
Yeah, that's right. Yeah, that's a good thing. But did you fix the twin fix? Is that screw twin fix?
Only one fixation.
No. This screw, this scaphoid screw, it looks like a twin fix.
Yeah, it has got threads. This is a Herbert screw, threads in front and threads behind. It has a compression device. You can see the threads here beautifully in this part. Yeah.
Because this looks like a twin fix as well. Twin fix, I used to use it, but it is awful and it's very difficult to get out.
Twin fix has never been available in India.
Oh, is it? Yeah. Well, it's fantastic design and everything, but it is a nightmare to take it out because it's a bigger section is rotate itself. So you cannot hold it anything. Oh God, it's awful. But it is, design is fantastic. It's really fantastic. I love that.
Yeah, I think twin fix is something like a variable length cancellous screw we have. The front portion is independent of the barrel, the back portion.
Yeah, that's right. That's
Yeah,
right.
that's correct. Yes. Yes,
It's
sir.
good design, but it's a nightmare to take it out.
Yeah. Yeah, I've just seen in American Academy stalls. I have not seen anywhere else.
Yeah, I've done quite a few, but twice I failed to take it out, so I stopped.
Okay. Yes, Parag has a question.
Sir, no, not a question. I must appreciate the clamp that you have made, round shape. It is my humble request that you should make it commercially available.
It's available commercially. Shivashankar Orthopaedics has done that. It costs about 30-40 rupees only.
Shivashankar. Okay,
yes.
Okay.
It's a Pune-based company.
Okay.
Yes.
Yeah, that's very good.
Excellent.
Yeah.
Yes.
Because earlier I was using the just clamps of square. That also is very cumbersome to the patient. So here, this is I can use it anywhere, especially wherever I keep the K-wire outside the body. I just apply this at the end of the K-wire.
Yes, sir.
1.6.
Yes, sir.
Yes, 1.6 or 1.8, because I normally use 1.8 because they are the Elizero wires which is cut and left out.
Yeah.
We use the K-wires.
Yeah.
Yeah.
So
Yes.
do you ever need to pass K-wire in scaphoid from the base of trapezium, or you always pass from the tuberosity or at the radial side of the scaphoid, or do you decide based on the fracture configuration?
Subhash? Yeah.
Me too. No, I never pass it to the base of the scaphoid. No, always side.
If
Side, from the side.
Base is very small.
Yeah. Okay.
No, it's not.
No.
Why you spoil the joint? There is a joint down there, and scaphoid that always trapezium is a bit of problem all the time. So you got to be avoid, because they joint always in this country got arthritis. So I try to avoid any kind of joint. It's very side.
Okay,
Yes.
sir.
Okay, sir. You can proceed, sir.
So yes, it is. If I can going back, it is a 9 months old. Now, possibly you are right. That MRI will be preferable, but speak the truth. Even in the MRI, your treatment exactly will be the same: open reduction and bone graft. So how is helping in the MRI? Our colleagues are everywhere in the MRI. But my practice, very little space for the MRI, because my kind of line of treatment will not change that much. What will happen? Yes, it is that telling the patient, look, this is avascular, it will not work because of this bone become destroyed, nothing much. That's I can tell beforehand also without doing that sophisticated kind of investigation. But MRI has got a scope, is fantastic kind of investigation. But in my clinical practice, is very little space for that. By line of treatment will change not that much. Because if I cannot see that much what's happening down there, I know that it is a scleral down there, everything, and that is becoming non-union. MRI will not give that much information to me any further than this convincing the patients. So exactly same way I can make marks where I'm going to make incisions, because that's I made a mark. Reason is that you can make incision here, you can make incision there, or more exposure. So that's why I always do that way. And again, I'm going all on the side of the trapezium like that way, and going to try to. My one is going down that direction, so I'm going to change that direction down that way. And this is that scaphoid view already that way. And again, you got what's happening now. Here you can see that I'm going to go to the much more on the ulnar side. So I got to pull it out. And then I had a scaphoid drill, I put it on, because when you have seen, I made already false hole. When I try to do that direction, it not much space down there. It always go back to that hole. So I tried to make a bigger hole down there, just a little bit of nick down there. And then I got enough space to manipulate, space to mobilize that direction. So now you can change the direction down that way. And once you change the direction, I can avoid the false hole and go in the right direction. So sometimes I had to do that things and just put this screw on this scaphoid drill, and the screw come out. This is called this Akutrack screw. It's a different kind of threads. I put it on. So that's what X-ray looks like at the end of the day. And that is that fracture. That is the 9 months. And that's after 6 months of the fracture phase. And now we can see that it start to revitalize the tissue. So after having that problem with this 1.2 scaphoid wire, which is having a track different directions go, I use now 1.6 millimeter K wire. That have a much better stability, and I can manipulate much better. This is the X-ray. It's a few weeks old. I put it down that way, exactly same kind of way. I made a mark on the surface marking, 1.6 millimeter going down that way. This is quite strong kind of wire, so I can change the direction, different direction. You can see the ion, again I gone to this ulnar side, I pulled it out, and I change the direction, and I can easily make a new trunk without any problem. So I use now all the times with 1.6 millimeter K wire. And once I made a 1.6 millimeter, then I changed from this 1.6 to this called this 1.2 millimeter scaphoid wire. And you can see this is that I took it out from that way, and then measurement was taken for the another 1.2 millimeter K wire, then scaphoid drill used, and the screw come on that. So that's the fracture, and that's the fixation. That's after 6 months fixation on that. That 8 weeks after the initial injury, that's about to going to a non-union, exactly same way. I made a mark on that. And again, I started to going the wrong direction. I can easily change the direction of that 1.6 millimeter. And now, again, it's going to wrong direction, the scaphoid view, though I have changed from the AP view, I can easily change the scaphoid view with a different direction. Again, I pulled it out and pull it down that way. So this, I'm trying to say that 1.6 millimeter K wire is much better to use initially to get a much better kind of positions, and my aim is trying to go to the proximal pole as much as I can do. And then change that one by. Now here is a little bit of problem here. When you take this 1.6 millimeter out, now putting the 1.6 millimeter is very sharp end, it's very difficult to get the hole down there. So I put that, before taking it out, I put the K wire near to down there and take it out, and then put that 1.2 millimeter K wire on this hole. Otherwise, sometimes it's quite a bit of fiddling to get that hole. Now, during that drilling, I don't know what happened. It changed the position of the K wire. You can see that I'm going to be in the wrong direction, which was not very liking very much, because that was a good position compared to the here. But still, I accepted that. So fix it that way, and that heals. Now, in case of non-union, when does not need bone graft, I don't know whether you believe it or not. This is that 34-year-old patients with the junction of the middle and proximal third. This is a big cyst formation here. Now, should we do that bone cancerous bone graft from the ear here?
Yeah, we should do. There is a gap there. I better to do bone graft and fill it up.
That's right. That's called is a real what you call treatment of that, and that's is a conventional way to do that anyway. But I didn't do the things. I just simple way. I just fix it up. Again, I've said 1.6 millimeter. I've tried to explain that how much kind of manipulation or maneuver I can do with 1.6 millimeter. I pull it out and just to the direction right. And once I get that direction right, in a closed direction, I pull it back again. I put this K wire down to this proximal pole, but is again going to the volar side. You can see this is the cavity, this is the fracture down there. My aim is to go proximal pull as much as you can do. Have it better. So what I changed 1.6 millimeter to 1.2 millimeter, then I measured it down that way, and then I fixed it that way. And that is the finishing theater. That is the X-ray, initial X-ray. That is the X-ray after 8 months post-op. So now the question is that, do you really need bone graft? What happened to this one? 18-year-old male patient, cerebral injury, did not attend the hospital. Pain continued 11 months. He came to initial injury. Big cyst. Again, if I'm going to say, you can see the bone, still he has not been visual plate down there. Now, if I'm going to take this X-ray to any kind of special hand surgery unit, big place, I'll be criticized not to think of the bone grafting down that way. That's true, as we did the last time. But I didn't do that. There's a big cyst down there. I simply just 1.6 kilometer going down that way and push it down that way. Then I changed 1.2 millimeter, remit down that way, and that fixed it. This is the initial X-ray. Sorry, and that's the X-ray for 6 months. There is no cyst anymore. So you can criticize me not to do the things, but again I say that I just slightly walk in a side lane. What are you going to do? 19-year-old male patient injured the wrist, did not attend the hospital except 11 months time. You can see that this is a bit ulnar deviation down there. Now we have to reduce the things, and that is kind of closed down there. I'm sure my hand expert specialist will do the MRI to see what is the positions of the proximal pole, which is more likely to going for it devitalized. So as well as normal kind of surface marking I'm do, and I put this QR on that way. And again, this is not very big area. My aim is go to the maximum hole of that bone. Problem is that I always stop my QR up to that level, because when I'm going to hit that way, I know that I'm going to rotate that one or something. So very carefully, I just try to hit, and very slow kind of power drill, I use it to go down that way. Then I once I make a hole, and then 1.6 to 1.2 millimeter QR, and then I drill it that way and fix it like that way. Still there's a bit of gap down there. But that is the X-ray of post-op, sorry, in the theater, and that's X-ray after a few months' time. There is no gap, there is no cyst. Now, how are you going to do this one? It again is a big cyst, slightly bit ulnar deviations. Bone graft? Any comment?
Yeah, I have a small comment. My decision to do bone graft in the middle third fractures also depends on whether I see a DC deformity on the lateral X-ray. And if I see a DC deformity, then I'm more inclined to do a structural bone graft like an iliac crest bone graft. If I don't see a deformity, I might just do a cancellous bone graft, or I would just put a screw the way you have done, though I must admit that I don't have the courage to put only the screw. So I'll end up putting a small amount of bone graft.
Yeah, that's absolutely right. That is the way of teaching and a way of doing that way. But as I say that there is not much problem with this any kind of DC or anything. That's holding like that way. So that's the way I do. Again, it's DC down there. But as long as I can reduce that fracture, that will be fun. I'm happy with that. So that's my surface marking. And my aim is to make it as maximum amount of pull I can have it, and I can reduce the fracture, ulnar deviation. I pull it down that way, and go to the looking for this pole. And I managed to get that pole.
Okay. Sir, I have a question
Yeah.
from Dr. Shashikant Ganjale from Sholapur. He has asked, how many times you poke this K-wire if you are not getting it properly in the distal pole? How many times?
As many times as you need to do that. My aim will be heading for a pole, proximal pole. It doesn't matter how many times. But if you take 1.6 mm K-wire, you got enough space to bypass your pole sole. But as I said, you must stop the K-wire before. You cannot have a effort to have a pole sole on the distal to the fracture, rather proximal to the fracture.
Okay.
All the pole sole, what I make it, I can do up to there.
Okay.
But once you make a pole sole on this distal to the proximal to the fracture, you had it. You know you're going to change it.
Yeah.
So that's why I can do as many times. That's why I stopped every time up to that level. When I leave that my K-wire at the end of the fracture, then I know where I'm getting the direction now.
Okay.
So yes, I will try as many times as possible. It doesn't matter. Time is not the matter. Matter at the end of the day, how you fix. These are human beings. You got to fix your utmost way. Because I maybe feel I'm quite experienced. It doesn't matter. Matter is that I got to do as many times to get a perfect reduction and perfect fixation. So once you get that maximum pull and that there is not much displacement down there, I took the another K-wire to subdistraction and then drill it and then fixation down that way. And that's that X-ray and there's the fixation after that. Now this young man, 27, and he discharged from the patients as because they couldn't see A&E, they couldn't see any fracture, but there is a fracture if you see very carefully. But you cannot blame to the A&E doctor because there's a new doctor, everybody. But somehow he came back to the hospital again and then X-ray. And this is the X-ray. Looks like it's getting a non-union. Now, also this one, I thought that because this pole looks like so tapering, I thought that I might not get the whole kind of pole. So I'm going to do the dorsal approach is integrate. So this is that dorsum of the wrist. I just make a small incision about few 1 inch, then take all the extension out. And this is my knife. Here I just take care of the X-ray to see my knife making a hole of the pole, maximum on the proximal pole of the knife. If I make a hole down there, then I'll be in real trouble. So before making any hole in the capsules, I just see with my knife where I'm going to make a hole. Once I make a hole, I put this K-wire on exactly on the pole with a full flexion of the wrist, which is I need a very good assistant for that to keep the full flexion. Otherwise, what will happen if they have any extension, this K-wire in the dorsal area, it's going to break it up. So you got to be careful, keep all the flexion all the time. And then I just, once I managed to get the right direction, I just pass it over. This is not a very easy job. It's quite tricky. You got to be careful because you got to keep the wrist always in flexion positions. And then after having a good position of the K-wire, measure it up and scaffold and drill, put it on, then screw, put it on, right direction. This one I don't have to think of that much pole because as long as I can get a good bite from the proximal fragment. So that fixed fracture at the end of the day, 18 months I consider that. So this one again, I'm sure many people will do the bone graft, but I will do this one is anti-graft. Those who are doing the first dorsal approach, you better start with this quite a bigger space down there. It's easy to do that. Again, I put the knife on that way, making sure that I'm making a capsule incision is the right place. And that my K wire going down that way, giving the flexion, like that in the pole. And then I'm pushing down that. And you can see that is going slightly down direction, but I changed that, pull it out, and change that better position on that way. So that's the beauty of the 1.6 K wire. Then once I get the right direction, I put the 1.2 millimeter K wire and take it out, put the screw, put the drill, and the screw come out. So that's that few weeks after the fixation. That is about 4 months after the fixation. Now, this 30-year-old male patient injured to the wrist, X-ray show no clear fracture. You can see that much of, you can see that. But as because of the pain, immobilized with the POP at the wrist. And then the fracture is X-ray of the 3 weeks, fracture appeared down there. It's very difficult to believe that thing. But again, the same kind of fracture is a DC, like that way. And there's a little bit of cyst started forming that way. This one I fixed with this dorsal approach. And there's a big cyst formation of that. That is the 10 months, 10 weeks, and the big cyst formations. Now, should I do this MRI, this one?
Yes, definitely MRI should be done to ascertain that it's a very small fragment proximal. So,
that's right. And a
yeah,
big cyst.
so
Yeah,
big cyst, and you should also add bone graft in this. Yeah,
absolutely, absolutely right, absolutely right. But I didn't do that. Believe me or not, I just took the theater. There's a knife down there. Do you believe me? I didn't do that. Hardly
yes.
I do for MRI. So I put the KY down there, and as normal, I put it down 1.6 square right direction, giving the flexion, full flexion of the wrist, going that direction. And then once I have it, you can see that AP view is not that bad. When the slightly lateral view or a scaphoid view is gone slightly on the side way, but still in the good positions. So I will change it to 1.2 millimeter K wire, scaphoid drill, screw come out. So that's that immediate X-ray. That's the X-ray after 8 months. So that is that your big cyst small, that is 8 months after that. This one, 32-year-old male, 6 weeks conservative treatment, is a bit more proximal. And again, you see down there.
Yeah.
Exactly similar way I'm going to do that thing. This square going a bit more kind of polar side, so I change the direction and try to put it back more proximally. When I go that way, you can see it's gone nearly much more polar out of the process. What I did that one, so I took that one out, I put the 1.2 millimeter to block that one to hold so that the false hole. So then I made another K wire, I put it on by the side so that I try to avoid this truck, because that is dorsal approach is quite a tricky one to go down that way. So I have to avoid this false hole to block it. So I'm going to go. So that's the way sometimes I do that way if you get a false hole causing the problem. So after having a reasonably good positions, I measured it up with this subtraction and fixed up this X-ray in theater. And that's X-ray after 8 weeks of the operations. So the patient failed to attend the clinic. So at least he's getting joining up. There is no cyst anymore.
Sir, may I ask a question?
Yeah, yes.
Yeah. So what is your immobilization protocol all this for all these fractures?
I put it in a proximal pole. I put on a back slab for a few weeks. In a mid fixation and the what you call retrograde one, I put the only crepe bandage.
No thumb spiker cast or anything.
No, not that. If the good question. Now the question is now how the patient is reliable.
Yeah,
If
true.
the patient is reliable, but if the patient is not reliable, then you got to be careful. You got to judge on that bit. On that.
So even if the fractures are old, some of the cases you have shown more than 6 weeks or 2 months old, you choose the same protocol of immobilization.
Yeah. Only some of the cases I sometimes do the bone stimulator.
Okay. Okay.
I don't know whether it works or not, but as because this hospital has bought that things, sometimes I use that thing.
How does it? How do we do, sir? Bone stimulator.
You know that there's a kind of it's a magnetic kind of pulsation goes to the fracture site.
Okay. Okay.
That's a point. Yeah. Yes.
Can I ask a question, please?
Please.
Dr. Halder, what is your indication for bone grafting? So far we have seen that you've been treating these very successfully, where others would vouch by bone grafting, and you have completely surprised us with your results when you've done these without bone grafting. So are there any indications for you in your practice where you would consider bone grafting?
I'll come back. Next one will come back. I'll give you an answer on that.
Yeah.
Yeah, I will, because that is my. You can criticize me. You can criticize me that Mr. Halder, it is not norm. It is completely out of a kind of normal process. That was my whole life is done that way. I always traveled slightly different track, and so many people criticize me, but I still survive, just showing the result. But somehow or other, it does work. I don't know. Because
Mr. Halder, there is a question. Closed surgery involves a lot of radiation. So how do you measure it and what precautions do you take? That's the first question by Dr. Virendranath Gaur from Delhi.
Well, is a very selective questions. Radiation. How much radiation you want? As many radiation you want. Yeah, if you put I put you in MRI, is 100. How much of the radiation you put it on? So yes, I try to save my hand and assistant's hand as much as possible, and I see the X-ray. Once you know how this KOR is going, is not much radiations of that much. It takes this operation takes half an hour to do that altogether.
Okay.
There is a fixation, half an hour to 40 minutes maximum. You need to do that.
Yes.
So yes.
Actually, there is a study done. Actually, a normal orthopedic surgeon can do about 750 interlocking nailing surgeries under Shyam. If he's using proper radiation gear like the thyroid shield and as well as the X-ray shield of at least 4 millimeter thickness. That is a study has been done by Dr. Vikas Agashe from Bombay. That's a beautiful study. So one should take care of all those things, and we have to step back few feet away when we say shoot for the X-ray. That's another thing which also reduces the radiation. Dr. Halder, there is one more question from same Dr. V.N. Gaur from Delhi. Exchanging 1.6 KVAR to 1.2 millimeter KVAR may endanger the reduction. How do you take care of this? This is his real question. So,
well, that time you got to be careful. Once you have good reduction initially and your resistance holding the hand is steady, that particular of the 1 minute, 2 minutes times, it doesn't get that problem because reduction is already done without any kind of manipulation or anything, because reduction is already done before. So it doesn't displace any further. It never happened to me. As long as it doesn't move the wrist or mishandle things.
okay. Yeah, you can proceed, sir.
Yeah. So this is that more proximal fracture. So it is difficult to fix it up, but it can be fixed. And if you don't fix it up, it is more likely to get a vascular necrosis the way it is going on. So I did exactly similar way, always made a nick on the capsules with this knife, putting on exactly on the proximal pole on the area. Then this particular one, you can see this it's called a very sharp pointy forceps. I put it on first, before putting any KY, this one I got to make sure that I'm in the proximal pole, making it sure. So I did not make any kind of hole anywhere with the 1.6 K wire, because it's quite a sharp end. Once I make the right positions, then I put that 1.6 K wire on that position. Once you get the middle part of this kind of small little fragment, you got to be careful that way. Easily we can split that way. I could have been gone to that direction, which I pull it out and change it with a direction, and go in the right direction, and then change 1.26 kilometer, 1.2 kilometer, and carry this fixation scapular drill, and this Agutrax put it on. Now here is a slightly bit inside, because that is the most important thing. Otherwise, it might problem with the wrist joint. So that is the things. There is immediate fixations, and that is after 8 months. Now this bone graft comes. I do the bone graft, I do the open reduction, not that I'm always do like that way. So see that fracture, how we in the Western world, you thought we are the best in the world or something, not necessarily all the times. These patients started to having a conservative treatment. This is the cyst formation down that way, then come that direction, then come this, then come this. That is the 11 months patients coming back to the clinic again and again, again and again. Can you believe that? And we thought we are the best in the world to give the service to the public, and we are free. All the patients are in, and everybody born in this country, they're completely free treatment get here. It's a lucky place to be born. But still, so many things happen. Now, how are we going to do this one? What are we going to do? I'm sure MRI is the best first option to, is that right?
Yeah. We should know the vascularity of this fragment, because already it is white in color. So it looks like the proximal pole as well as the distal pole. Normally the distal pole, which is huge, doesn't show so much of opacity on the X-ray, but here I am doubtful. Both the fragment appears to be avascular.
Yes, that's the thing. Yeah, I'm also sure that. So anybody else? So yeah, I'm sure you're that way. But somehow, either believe it or not, I didn't do that. I thought that again, so I had open reduction here. I opened it up. I got one little setup, because this very nice thin osteotome, as well as a very fine nibbler you use for the finger. So I clean it up nicely and clean it up nicely. And I put this corticocancellous bone graft on the iliac crest. This is the size of the bone graft from the iliac crest. That is the most important part of the whole operation. I do the operation here, minimal kind of incision, as the book says, like that way. And when you make a capsule incision here, is just neither any kind of manipulation, either part of the kind of bone, just middle part is curate it up and try to reduce this little humpback deformity, and make sure and put the one osteotome inside the hole you created, and the exactly same millimeter of the diameter of the bone graft you're going to take from the iliac crest, only one piece of the other, not move it. And from there to there, that you got to be in one piece. That is no, it is very difficult to take the one piece out like that. Always there is a bit of crack somewhere. So slightly have a bigger piece down that, then I can trim it out that way. So that's the bigger bone graft I took it up. And then how with the fixation now? That is the problem. When you put the KY down that way, then sometimes it get split on this kind of cancellous bone, because it is from the bone graft position. So my KY are going down to the wrong directions, and I tried to change the position that way. So I tried to hit that way, and I got reasonably good. But this is the thing happened. It gone down to slightly on the radial side. So I was not very happy. You can see that much of space I can have a bite for the proximal fragment. So I tried to change that one. So I took it out, and the hole I already made it. I blocked it up with the one of the K-wire. Then I put another K-wire on by the side. Once I get it by the side, then I took this 1.2 K-wire out and trying to go this middle section down there. And this is my bone graft, and I tried to go the middle down. I took it out and changed it to 1.2 millimeter K-wire. And then, I put the drill on that way and fix it with the scaphoid screw.
Instead of taking bone graft from the iliac crest, why don't you take from the distal radius itself? Because it's a small piece of bone you require, which makes your life easy.
No, you need a cortical bone graft. Here is a humpback deformity. You need a big, thick cortex here to get it out that way. You can
take it. Yeah, cortex. You can make a small slit sort of that in distal radius and take a good cortical bone also. Yeah.
That's not good cortex. You need to be a really hard, nice, good cortex down that way. Anyway, okay, I never took the cortex on the wrist. I do not have a problem with the wrist. I took the always iliac crest. It's a very nice, very tough bone, very tough kind of cancellous as well as a cortical bone down there.
Yes. Okay.
And that great result you will get it. 10 months.
Great.
Now, this 22-year female patients, when fracture of no fracture seen is scaphoid, use the wrist brace. So this happened here again. Now, how the big kind of non-union now. It is now 34 months.
Yeah, almost 3 years.
Almost 3 years. And you can see that is already white. So, any suggestions?
Like the earlier one only. Dr.
Yes.
Parag is there. Yeah.
Yeah. So suggestion is definitely I would consider a strut bone graft in this case.
That's right.
Yeah, and fixation with the screw.
That's I'm 100%, 300% agree. I did it that way.
Yes.
That is my bone graft.
Yeah. Yes.
And that's the fixations.
Yes, Pankaj, you have anything else to add?
No, I'm always very keen to see the lateral X-ray preoperatively to judge what type of graft I want. So that's my only comment. I'm more keen to see lateral X-ray than MRIs and CTs.
Okay.
That's fine. They have a lateral X-ray down there, but I didn't show you that way. Yeah, sure. Always have a scaphoid view anyway. They take it down.
Yes.
I just showed you when the maximum amount of what we call this non-union you can see. Yeah, that's that. Because always this scaphoid view down there, 4 X-ray down there. So that's 11 months after the operation.
Yes, 15 months. Okay.
Sorry, bigger one, 15 months. Yeah. So how are you going to do this one?
4 years.
This is 4 years. You can see the condition of the bone. It's only 26. As we said that this is a neglected fracture, scaphoid really. So it's not only your place, patient comes late. Is here at some we don't do right to the patients. Your place patient comes late, but we sometimes miss or sometimes we don't do right treatment in the beginning, or we don't know how to do that things. So I did exactly the same. I took it out, cleaned it as much as possible, fix it up the right way. This is my bone graft. It is a corticocancellous bone from the iliac crest. That's fixation now. And that's that fixation, we will get it. And that's after 6 months.
Yes. Subhash, just interrupt you for a minute. Dr. Parag Lad has another webinar at 7:30. He will be leaving. He wants to say bye-bye to you before leaving.
Oh,
Yeah.
thank you. This is my last
So,
one.
so Dr. Halder, as Dr. Pankaj Ahire in the beginning said, experience is, in last 1.5 hour to 2 hours, I have learned very few, lot of things that I also need to think about in my practice that I learned from you. I learned most accurate close reduction techniques and percutaneous fixation techniques for the 5th metacarpal. Your results were extremely amazing, sir. And in your presentation, I have realized your documentation is absolutely crystal clear to preserve Shyam images of each and every case, and to do this kind of so much variety of presentation that I learned. Usually we have a documentation of pre-op and post-op x-rays and 1 or 2 images. And I'm really thankful to you, sir. It was a great
No,
learning experience from you.
my pleasure. I'll tell you, and you can tell your juniors also.
Yes, sir.
I went down a few times in a theater in India, and I find very difficult to convince the radiographer to keep all the X-ray. You know, my hospital here,
Yes, sir.
it is mandatory that radiographer will put the button on all the X-ray. My X-ray, 200 to 300, 400 X-ray, they keep it,
Yes,
and they wait for me. And if you come to my theater, I have got a 30,000, 40,000 X-ray in my archive. Hospital make a special kind of line for me. Every single X-ray I save it.
Yeah. The simple technique of blocking of all the fingers by putting a crepe bandage and keep the finger that is injured for the surgery was also one of the good learning point for me, sir. I am really thankful to you. Yeah.
Very simple things, because that's the way, I mean, you can think that how much amount of problem created by all the fingers and radiation to the hands.
True,
No,
sir.
thank you very much. It is my
Thank
pleasure. I hope I'll see you one day when I will in.
Dr.
Thank you, Parag.
Shivashankar, sir,
Thank you very much.
Thank you very much. Yeah.
Yes. Okay, you can proceed, Dr. Halder. Sorry for that interruption.
I think that's the last one, really.
Okay. Okay.
Yeah.
Now we can have some. I'll try to show a case.
Yeah.
Dr. Halder, what's your comment upon this type of fixation fracture? This is boxer's fracture, fixed with a bouquet technique of wires which are blunt. It says blunt wire which is used.
Yeah, that's quite good fixation. Is a crosswise, but it is sometimes quite difficult to mobilize this. You can realize how much a big hole you have to make in this joint, and it's sometimes if you had a smaller medullary cavity, it's very difficult to do the 2-wire. But that is the conventional way to do that.
Correct.
And sometimes quite fiddly job as well. And this kind of sometimes I don't know we have got here is the kind of pain problem after the K-wire out, because you got to take quite a bit of bigger hole to take the out from the joint. But overall, this is that is a conventional way to fix it by close method.
Okay.
The amount of time I will use it, I can do the 2 K-wire in a 10 minutes time. That's what I do.
Yeah, that's correct. And this luckily fracture 5th metacarpal is common, and we have from the side area to pass these K-wires in this fashion. This is Dr. Ganjale from Solapur who has shared this picture to share with you just now.
That is this norm. That is the book technique.
Correct. This is a 4th and 5th metacarpal fracture. Again, both of them fixed with one fixed with 2 wires, another 6 with single wire.
Yeah.
This is the just clamp. Instead of using cement, this is another very old X-ray. In 2004, 2006, this patient has been treated. I just searched and tried to get one more X-ray to show that this is how we fix the K-wires with link joints, what we call as just link joints. Okay.
Yeah, that's
Yes, we can have some question and answer on all the things he has discussed. Pankaj, you are unmuted. You can ask the first question.
Yeah, Mr. Halder.
yeah.
So between the cases, the first set of scaphoid non-unions or delayed unions that you showed, and the second set of scaphoid non-unions in which you used the IDF-based bone graft. So what were the different indications in the second set?
Yeah, because one is a complete destruction of the bone, both cortex.
Okay.
There's a humpback deformity. Other one, which is fixed up, is only cyst formation.
Without any deformity.
Without any deformity. Because both other side of the cortex has not damaged that much. There may be one kind of just deviations of the DC down there, but there is no other. But other one, which is I fixed the cortex, is complete destroy the whole kind of cortex, both sides, all sides. So you had to have maintain the length and the deformity, especially humpback deformity. That you
Sure.
cannot do.
Sure.
Yes. Yes, Abhijeet.
I think I don't have any questions as such. Just comment to say that this is like reading the close reduction book all over again. John Chandler's book. I don't. So as young surgeons, we are always given to believe that the dogma of surgery or being aggressive in our treatment. But this is a whole new kind of a view, a completely different view on how seemingly, difficult fractures where I would have not considered anything but surgery or bone grafting for that matter, or plating for that matter. Mr. Halder has shown us so convincingly and so beautifully how you could deal with these fractures in a not so conventional but yet effective manner. And thank you very much for that, sir. Thank you.
Oh, my pleasure. I don't know, I'm taking permission from Shiva. Should I say here? But
Yes.
it is for the information of the younger generation. I will tell you that all these things, what I'm doing now, is set up here in this country. We got nearly 90 register level in my county, my whole Yorkshire region. There are now 90 hospitals. So we usually get 3 or 4 register rotations, 6 months working in every consultant. So I got one kind of register come from South Africa. He's just one extreme. He's 6'6" tall. I'm just quite a bit down. I'm not very, very tall. So he saw this kind of reduction, and he was raising the eyebrow and said, "Mr. Halder, you do this kind of things. We don't know anything about that. And those who doesn't work with you, nobody knows that thing. So you must do something." So what you do is that we must work a course. So I arranged a course. I ran that 6 years course. All this my techniques and other things, and I got a permission from the Royal College of Surgeons in England. They come down to visit us. That chap who came from is a Professor Levy, and he's supposed to go 1 hour. He has a whole afternoon to seeing that thing, and he said that to us, you must put something in the writing, otherwise you will die, that thing will die with you. You got a few gray hair. And you believe me not, I wrote a letter. I wrote one book. I don't know whether if you listen or not. It's 2,000 pages, all kind of things. So tibia, femur, humerus, and hand. Is published by JP. I shouldn't say like that way, but it is on the market now. Each and every little technique, all close reduction, how do we do that thing? How to passing the K-wire, whatnot. So yes, it is kind of any kind of reduction, a kind of art. It is not evil. In my life history, I met Professor, you tell me the best people in the world, and I fortunate enough to handshake with them, Professor Rockwood, Green, then Professor Roman, Professor Shivashankar, everything are that way. They raise their eyebrow. How can you reduce a fracture like that way? And that kind of things. I have got a special hand invitation from this Professor Rockwood in his own department. So come on and present the paper. So yes, you got to try your best to reduce. You got to have a kind of respect the tissue. No point of a knife and cut the tissue and open the things, and it's like a butchery job. That's, you got to avoid that thing. You got to respect the tissue, and more you respect the tissue, it nature will heal it up, and that's the one I try to follow the things like that. But yes, it doesn't mean I don't open up. I do open up when I try my best not to do anything. But if you try your best, you will find the way to fix it.
Abhijeet, I have been listening to Dr. Halder. I heard this in 2012 for the first time about hand injuries and tibia, humerus. So since then, I have been requesting him, and every time he has mesmerized me. This is probably 6th time I am listening this talk from him. So, but every time I learn something new, and everybody will be like you. Even Dr. Tanna, 2 years back, we had in operative nailing course lecture by Dr. Halder. Dr. Tanna came only in the afternoon. Before lunch, he was supposed to give talk, and he was supposed to leave. During lunch time, I told Dr. Tanna, sir, I would like you to stay back, and definitely you will feel something definitely new you have also learned from Dr. Halder's talk. And he stayed till 6 p.m. till Dr. Halder finished all his 3 lectures from 2 o'clock to 6 o'clock. Dr. Tanna stayed, and at the end, Dr. Tanna said, I thank Shivashankar for asking me to stay back. So this was the comment he gave on that day. So that's what
Professor Thane is a
Yes.
fantastic man. I salute him like anything. He's a really, really master of the master. I am nothing to him, really.
No, but definitely, so there is something to learn from everybody, sir. So we have learned a lot from you. Definitely, I'm not going to leave you unless you have your next talk on humerus as well as the tibia sometime in near future, say around 1 month from now. So I request you to keep it ready right now so that all of us will be benefited. It's not experts like Dr. Abhijeet or Parag or Dr. Ahire in your talk today, but all the youngsters will get a other perspective, other side of the coin, because we are all nowadays exposed only to treat this fracture by operative surgical technique. Yes, Abhijeet.
So first and foremost, sir, thank you very much for giving me this opportunity. I think I have enjoyed it as much as Dr. Tanna did, perhaps. And the second is, after listening to Dr. Halder, I'm really beginning to wonder if I really should be called an expert. There's so much to learn. There is so much to, to assimilate. And I want to thank you, Mr. Halder, for all the teachings, for your wonderful and very simplistic approach to these complex problems. And I'm sure to, revise my thinking about dealing with fractures in my career, in my future practice. Thank you.
Oh, thank you, Abhijeet. It's my pleasure to see you here. Hope I'll see you again. But it is not. I as I said that I never consider myself with the experience. I'm learning every day. Wish I could have another few years to live to do something. But yes, this is always the other side of the coin. You got to think very carefully. It just not necessarily what one of the anatomy teachers says. Sons is always intelligent than the parents, rather children. But that's why tomorrow you are much intelligent than I am, because I am in other generation. You are in the forefront generation, so you will be much better than me. And you got to have a better mind to see, because you have to open your kind of windows of your brain, different direction, take more and more, and just think of the better things. Yes, some of the things I'm showing is not conventional, but it does work quite well. I'm working last 45 years.
Yes.
And I work in
what Dr. Abhijeet said in the beginning, experience-based medicine we had today. Yeah. Pankaj, you have anything to add? Meanwhile, I'll ask Neeraj Bijlani if there is any online questions to get them on board. Pankaj?
Yeah, I mean, it was a fantastic learning experience, and it was a privilege to share the screen with you, and of course with my good friend Abhijeet and Parag, with whom I got fantastic friendly relationships. Uh, it's a few things which I always wonder, especially with percutaneous K wires, Mr. Halder. We all started orthopedics with percutaneous K wires, and over the years, my practice has seen lesser and lesser percutaneous K wire use. I wonder whether it has something to do with the weather that I work in, whether percutaneous K wires with low humidity, low amount of sweating works better in the climates like Northern Europe, and is not too suitable for the tropical climates that we have. I always wonder this because if there is a problem to be seen with percutaneous K wires, I have seen it. And though I can attribute a lot of it to my poor techniques, but not all certainly. Not all certainly. So I keep wondering whether weather and climate and so many environmental factors play a role in choosing what we choose for our patients.
I don't know. I born in India. I just qualified in India. That's it. I worked my whole life in the Western world, so I don't know the Indian situation. But at the same time, you got to think very carefully. India is always, there is a kind of questions always arise. That is suitable for what's suitable for Western world, whether it's suitable for the Eastern world or not. It is not things. I mean, this if you take a bit of nowadays, I can see these people are much more concerned and quite a bit of educated themselves, even though may not be passing through the exam, but they're really quite a good kind of general education they have got it. So yes, I have no idea whether percutaneous will cause any problem or not, but I'm not going to comment. But it's a very simple operation. But at the same time, is a money-oriented practice as well. If you do the plating of the things, it being money in your pocket. If you take K wire, do you think patients will give you that much money the same direct way? It is different that way as well. But I don't know. I've never been to practice in India, so I don't know.
So my concern is not only about K wire versus plating. My concern is about percutaneous K wires where wires are left out. It's very common for many young surgeons to believe that if you put percutaneous wire, then you must leave them out for easy removal. I don't quite agree with it because wires left out have their own problems. Anything that appears simple need not have a very smooth course. You need to master these techniques very well. You need to take a tremendous care of wires which are left out of the skin. And else the problems are quite a few, which many young surgeons may not want to acknowledge because percutaneous wiring is too simple to be discarded, too simple to be improved upon. So I think it many times tends to be used as an escape route. Okay, so what if I did not get a good reduction? I have not caused a soft tissue problem. I have not opened it. That's a very common excuse I hear, unfortunately. So I hope the young surgeons who are watching this see the mastery behind these techniques.
Yeah, that's right. Any kind of technique, it doesn't matter K wire, you open up and plating, you got to learn how to do the things. It is nothing to that. You got to learn it either what you are doing. There is a learning curve, and until you have got a learning curve, you will not learn anything. So you got to occur that way. So it doesn't matter what you do, what you believe. If you don't believe in a K wire, then you must not try. If you don't believe on systems, you must not try. You have to convince yourself that yes, this thing works, then you try. Please, I put in my both hands in my things. I'm showing you this thing, not necessarily I'm boosting myself that it does work. No, it works possibly in my hand. It may not be working in somebody else's hand. If you don't, it doesn't work in your hand, you must not apply that thing. You must do whatever you are expert. That's my beginning of my talk. Whatever you do, either junior or experienced, if you're happy with the systems, you continue with the system. But question is that happiness depends on what? Everybody is happy. If the happy you are, we will be stuck in the world. We will not progress. So what do you call happiness? That depends on that. Today we are happy. If we are happy, we'll never be tomorrow. The tomorrow is a different thing. So yes, but at the same time, if you are not happy, if you want to change your practice, you got to believe 100%, and then you, like when I started the gamma nail, everybody criticized 1980s, that very technically demanding nail, fracture the femur, blah, blah thing. That nail has not changed or technique few millimeter. But now, any kind of SHO, within 20 minutes can do the operations. Same instrumentation, same technique, nothing changed. Only you had to convince yourself, yes, these are the things I like to do the things, then you will find. When Henry Ford started the car, and his car was in 20 miles per hour. Nobody, he had a survey, nobody wants to drive the car because accident happened even at 20 miles per hour. Now, Ferrari goes 300 miles per hour, and people are driving 200 miles per hour without having accident. And if you have an accident, you come out of the car without any injury in a walkout. So it depends how you believe. And if you believe it does work, and if you are happy on things, you will never be a car from the Ford car to the Ferrari car. So that's the only things I'll say you. So yes, it's a believer things. If you're happy, you carry on. If you're not happy, please, please never ever apply something else. And if you're not 100% sure of that.
Yes.
Thank you very much, sir. Thank you for sharing your wisdom with us. Thank you.
Yes. Subhash, thank you very much. That was a great lecture, as regularly you have been mesmerizing us. So you have done the same today also. Definitely, I hope this will help a lot of people who will be watching this live, as well as they will watch over this weekend the recorded version, which will be available on the same link. I would like to thank Dr. Parag Lad first, because he has already left. I should not miss him out. Dr. Pankaj Ahire and Dr. Abhijeet Wahegaonkar for joining as panelists and initiate a very useful discussion regarding this injuries of the hand. I would also like to thank Dr. Neeraj Bijlani as well as Dr. Ashok Shyam from the Ortho TV for coordinating all this program. Thank you very much, and we are going off the air. And I would request you to prepare for your human